Good afternoon, everybody. We all welcome you to the second episode of the masterclass on facial rejuvenation organized by the Ophthalmological Society of West Bengal. Now let's start. Dr. Savita Kartoch will give you the welcome address.
On behalf of OSWB, a very warm welcome to all attending our master class on facial rejuvenation. We are privileged to have two esteemed faculty members, Dr. Kasturi Bhattacharjee and Dr. Aditi Grewal, leading a packed program with hands-on training on mannequins. We are looking forward to an active participation by the audience and a lot of learning for all of us. Thank you. And I'll request Dr. Joyita to introduce Dr. Kasturi Bhattacharjee.
Dr. Kasturi Bhattacharya, Madam, our main chief faculty in this session. As we all know, who is Dr. Kasturi Bhattacharya. However, just for it customary, I have to introduce her. She is a director of Sri Shankaradeva Netralaya, Guwahati, and also the head of the Department of Orbit Oculoplasty Aesthetic Surgery. He also practices cataract and refractive surgery. She owns many numerous awards, both national and international level, including AIOS Rangochari Award, Dr. APAOS Hunavar Award, and so on. She has also got the International Heroes and Star of India Award, APAO Achievement Award, and many, many more. She also runs fellowship training program, and our second speaker, Dr. Aditi, is her fellow also. She has a numerous lecture on orator in American Academy, APAO, ASOPRS, APOCPRS, WOC, and AIOC. She is not only these things, she is the first of many things, like she is the first lady ophthalmologist in India to have received 5 awards in AIOC. She is the first lady FRCS Edinburgh from Northeast India. She is the first and only lady ophthalmologist in India to be elected as the Vice President and President-elect of APSOPRS, held in Chengdu last year. Just a minute. This is from the APSO. This is the picture when just after the winning that election in APSO PRS. She is a multifaceted talent. She is a great administrator. She is a national level sportsperson in basketball. She is a proud mother of 2 beautiful girls. And above all, she is a very good Samaritan. She is a very good human being. With a lot of, he is involved in a lot of social work along with her busy schedule. So I welcome you all, Madam, Dr. Kasturi Bhattacharya, Madam, in this OSWB Masterclass on ocular facial rejuvenation. Next, I request Dr. Parag sir to please come and hand over the bouquet to Dr. Kasturi, Madam. Please, sir.
Now Dr. Madhusmita Behera will introduce Dr. Grewal.
Dr. Aditi is a double fellowship trained oculoplastic surgeon working as a consultant at Grewal Eye Institute, Chandigarh. She obtained her MD in ophthalmology from RP Center AIMS, where her MD thesis on injectable propranolol in injectable hemangioma under the guidance of Professor Mandip Bajaj invoked her interest in this niche field. She then pursued a senior residency in oculoplastic and ocular oncology at Advanced Eye Center, PGI Chandigarh, under Professor Usha Singh, who is also the current president of Oculoplastic Association of India. After that, she completed a dedicated fellowship in ophthalmic plastic reconstructive surgery and facial aesthetics under the mentorship of dynamic and dedicated Dr. Kasturi Bhattacharjee. She then returned hometown Chandigarh and is now practicing privately and has established a dedicated facial aesthetic clinic. She also has an excellent academic and research background, with her qualifying for NTSC scholarship in high school and obtaining a gold medal in MBBS. She has also successfully completed FICO and FAICO oculoplasty examination. She has won the Sujata Savitri Rao Award for best paper in oculoplasty at AIOS 2018. She has over 50 PubMed index publications and book chapters, as well as numerous invited talks at international and national conferences. In her free time, she loves spending time with her family, traveling, and Pilates. Welcome, Dr. Aditi. I request Dr. Saurav Sanal to present a bouquet to Dr. Aditi.
So it's academics now, and Dr. Kasturi Bhattacharya will take up the topic on the recapitulation of facial anatomy.
Very good evening to all of you. It's really such a big pleasure being in OSWB, especially in Kolkata. As always, I say it's like a homecoming for me. Very much deeply involved with Kolkata since my childhood days. Always I say my dad studied in Narendrapur, and I have visited Narendrapur so many times, met the Maharaj, and my Pishi, she stays here in Salt Lake. And many of my relatives are here. It's really wonderful, and thank you so much for having me here. So I'll speak something very basic, that is about the facial anatomy and how do we assess it. So before I start, I'd like to mention that it is always true, like we usually appreciate what we see, and we think that what we see is actually what it is happening. Just to cite you an example, so can you tell me like how many pictures are there in these pictures? Like how many faces are there in this picture? Can any one of you check it? Because I feel that each one of us interpret differently, and our view is formed by our own experience, and from which we take our own perceptions and a belief. So can anyone tell me how many faces are there? 3. Okay, Raka? 6. Dr. Saurav? He will say more. Anyone can give a guess? Definitely more than 3. That's why I always say, I tell to my students that what we select as data is our experience of the world that we see. But if we really look to this picture, this is one face that all of us have seen. Can you see there's one face 2, face number 2. There's a face here, 3. There's another here, 4. Then there's another there, can you see? This, the lady's face and the gent's face. And there's one here, there's face. This is also face. So total there are 9 faces. So that is what like we need to appreciate in a very different way when we do facial aesthetics. And especially it is very important that we see not only holistically on the face, but we need to see every point, because everyone is so beautiful. We just need to modify what the beauty they have. So facial assessment is something very important. And when I say that when we look to these different faces, like if I ask most of the people, everyone will say, oh, she's so pretty, she has got a beautiful face, beautiful nose, beautiful eyes. But being an oculofacial surgeon, what we are supposed to see, we need to see the 7 pillars of facial analysis. And these 7 pillars basically includes the skin, the muscle, the smas, the ligaments, the fat pads, the fascia, and the bones. So when we perform any of the aesthetic procedure, we should have a very thorough understanding of what the agonist and the antagonist of the muscle, how the bone behaves, how the ligaments, what is the extension of the ligament, and how also the fat pads are being arranged. So when I talk about the skin, when we look to the skin, we know we are people of different colors, different origin, and different texture. But we as an Asian, when I talk about Asian, we belong to 3 types of Asian category. One is the East Asian, especially the Chinese, Japanese, Korean. They have a different skin texture and they have a different color. The Southeast Asian, especially the Malaysian and the Indonesian, they are much like us. And we South Asian, especially from Bangladesh, India, Pakistan, and Sri Lanka, we also have a little different color and also little different texture. But the most important is that whatever the most important layer of the skin is the first layer, which contains the lipid, and that is known as the stratum corneum. And it is on this first layer we have the fibroblast, and we all know the fibroblast is the main source of the collagen, and this collagen which keeps us looking young. So the resistance to aging is credited to the thicker the stratum corneum, which we usually find in the Asian face. And when we do a skin typing, a very common typing of the skin classification by the American Academy of Dermatology is oily, dry, normal, combination, sensitive. So it is when we assess a patient, because when we start the aesthetic practice, it is not only we are limited to only Botox and fillers, because the patient now cosmetology, a different speciality has come which is known as the facial cosmetology. And this facial cosmetology can be done by anyone who is an MBBS doctor, any registered medical practitioner can be done. And interestingly, it has come in the course curriculum by NMC, which has also come to the dentistry curriculum. There is nothing like it is only in the dermatology curriculum, because dermatology itself doesn't have a course of cosmetology. So any MBBS can do a cosmetology treatment. And to do a cosmetology treatment, you should know very well about the skin, because the patient will not be happy. In fact, we call the client. The client will not be happy only having Botox and filler. They will want a better texture skin. They will need a shiny skin, glowy skin. So many things have come. So many energy-based devices have also come. So you should really understand, you need to analyze, and when you start your practice, the first thing is you need to buy a face analyzer. In a face analyzer, the moment you put him on the analyzer, you will have a 3D image, and this will actually tell you where are the wrinkles, where are the pores, where are the fat, and this really helps you to plan whether you will go for a simple peeling, or you will go for a wrinkle treatment, or you will go for filler treatment. Fitzpatrick is something which we usually use when we go for a publication. This is based on the color and based on the tanning. And this is basically, we Indians, we usually follow in Fitzpatrick 4 and the 6. Advantage, we have more melanin, so chances of some of the complication related to UV light like melanoma and all are much less. But the disadvantage is that this color is little higher than the rest of the other population. And the third is another classification which is known as a Glogau classification. This classification is based on the amount of wrinkle, which we say type 1, 2, 3, 4, and also which is corresponds to the amount of photoaging. Like the type 1 face will have less wrinkle, less photoaging. Type 2 will have little moderate. Type 3 more severe, and the type 4 will excess amount of severe. So this is a very basic understanding about the skin, but we should know the skin very well when we do a oculoplasty practice also, because many a times when we do a wonderful surgery, whether it's a lid reconstruction, blepharoplasty, we see that the patient behaves differently. The fibrosis may be different, the keloid might come, so we should know how to manage the keloid, how to manage the scar. So now this whole oculoplasty especially has become more of a facial plasty, speciality. So I'd like to show you this video. Under the skin, there are so many other structures. So we should very well understand what are the most important structure. And a very important structure that all of us should know is the muscle. Because when we start a Botox, injection of botulinum toxin A, we inject into muscle. So we should know how the muscle acts. And when we look to the forehead, there's only one elevator, that is a frontalis muscle. So when we lift the eyebrow, so that is my frontalis muscle working, and rest all the muscles around the eye, whether it is a orbicularis, or it is a procerus, or it is a corrugator supercilii, or a depressor supercilii. All these four muscles are basically the depressors of the eyebrow. So we should always remember in which direction or which muscle we are targeting. Like this lady is trying, she's giving a very sad look. You can see all the depressors are working, whether it is a procerus or the orbicularis. When we talk about a muscle of the midface, these are a happy group of muscle. Why? Because it lifts the lip. So these are the muscle we should not target when we inject a Botox, because these are all inserted in the lip, whether it is zygomaticus major, minor, or the labii, or the zygomaticus superioris, elegineus. So this, see, she is happy. You can see all the midface muscles are working. Then when we look to the muscle of the lower face, they are again the sad group of muscle. And this is basically the DAO, the depressor anguloris, depressor inferiorlis, and the mentalis. So when we are sad, you will say these are the muscles which are working. So based on how the muscles work, we should understand, and accordingly we plan the Botox treatment. So this girl is sad. You can see the muscles of the lower face are very active when they're sad. And another muscle which is also very essential when we do a treatment of the neck is the platysma muscle, which extends from the supraclavicular fascia up to the face. Then it goes, inserts into smash, goes to the orbicularis, and then to the galea. Understanding about the nerve is also equally important, and also the blood supply. I will not go much into the blood supply, but what we understand, the face is supplied by both the branches of the external and the internal carotid. The area around the eye is basically supplied by the branches of the internal carotid, and the whole of the face is supplied by the branches of the external carotid. So if I draw a line in the midline, so 2.5 centimeter from the midline is a very dangerous zone, because most of the branches of the internal carotid, they lie there, and sometimes while injecting filler, if it enters into any of the branches of internal carotid, it will lead to a vascular complication, and it can also lead to a loss of vision. So the facial artery, when it enters the face, after it enters the face, it separates into two branches, the superior and the inferior alveoli. Here it is in the deep subacute. Then it moves in the nasolabial fold, which is a superficial subacute. And when it becomes the angular artery, it becomes very superficial. So depending where the facial artery lies, we need to plan injection filler. Supposing we are injecting somewhere over here. Here we know the facial artery is not there. So here you can inject either subacute or a deep. Supposing you want to inject in the nasolabial fold. So where the facial artery lies, it lies in the deep subacute. So in that case, either you have to inject either on the bone or subdermal. Supposing you want to inject over here, where the facial artery lies, there is a branch of the angular artery. Angular artery is a branch of the facial artery. It is very, very superficial, subdermal. So you should avoid this space. So better you hit the bone. So depending how the artery it moves around the face, accordingly you should target where to inject the filler. Little bit of the smash, which I have already mentioned. It is basically a very important layer, having three structures, one superficial, one at the layer of the muscle, one at the deeper to the muscle. We sometimes call the deep plane facelifting. That is when we pull the smash below the muscle. And most of the time when we start as a beginner facelifting surgeon, we usually use the superficial, because just below the skin and the subacute you get the smash, and you lifting the smash, it gives a very good facelift. So once we are starting a career, it is usually better to deal only the superficial smash, and once we do more number of facelift, the mid facelift, we go for the deeper smash. Next is a ligament. I always like to compare the ligament to that of a tree. Like the tree has a root and branches and gives the leaves, exactly the ligament, the true ligament are always osteocutaneous. That means it arises from the bone and inserts into the skin. And if you see most of the true ligaments, they are basically around the eye. One is the ORL, that is orbicularis retaining ligament, both superior and inferior. The tear trough ligament, then we have the zygomatic ligament and the mandibular ligament. We should know that in the face we have different fat pad, the superficial and the deep. What we keep on saying, the SOOF and the roof, that is the fat pad around the eye, it is usually the deeper face pad. And this is a ligament. Lockwood ligament is very important, especially when you inject the filler. And sometimes why this is important? Because this is a ligament which usually holds the globe, and it separates the globe from the rest of the fat. Otherwise, if this Lockwood ligament would not have been there, then the whole of the globe would have been down in a much deeper layer. So it works as a fulcrum. This is a fulcrum which extends from the medial canthal ligament to the lateral canthal ligament, and then it gives it opens up for the inferior rectus and the inferior oblique, but this is basically a support to our globe. So these are basically the 7 pillars, which is number 1, the skin, the muscle, the fat, the bone, then you have the smash, you have the fascia, you have the ligament. So all these 7 pillars, if they are correctly positioned, then we call the symmetry, the face is symmetrical. So the symmetry is something which we always target when we do a aesthetic procedure. And when we looked, even if you look to my face, I don't think my face is symmetrical, because you'll see the right and left always differ. But what is most important, that at least the lip should be symmetrical, because when we talk, it becomes very obvious because we look to the lip, right? But if you really look to most of the people's face, I feel that everyone's face has a little, asymmetry. So we should know what are the magical 7 factors, and this includes the face shape, the eyebrow shape, then you have the forehead, the eye shape, the nose, lips, and the skin. Skin I have already covered, and the facial shape I'll be talking a little bit about it, and I will not include the others because today will be basically, when we'll be practicing in the mannequins, we'll be basically talking about the periocular injection, botulinum toxin A, and also the filler injection. What is a symmetrical face? The best way for the young upcoming facial aesthetic surgeon, we divide the face vertically into 5 feet, and each of them is a distance between the medial and the lateral canthus. If you just draw a face and you can see that there are 5 feet like this, that means it is a very symmetrical face. This is how we call it a vertically symmetrical face. And horizontally, if you can have a 3 equal part and divide the face into 3 parts, then we call it a horizontally very symmetrical face. This is what, if we draw a line from the trachea to the nasofrontal angle, and one from the nasofrontal angle to your subnasally, and then here to the menton, then if all the diameters are same, then you say a horizontally symmetrical face. But if you go to more advanced course, that is something which is known as the golden ratio. We call the divine proportion or the phi ratio. So this is something where not only the facial aesthetics, the whole is, even this building aesthetic is dependent on this phi ratio. This is the ratio where everyone has used, whether it's an architect or whether anyone designing a building or whether designing any other monument. This is a golden ratio which everyone needs to use in order to define it a totally symmetrical structure. When we do a facial assessment, first all of us, when we start to practice, we need to do a full face assessment, whether it's a plastic surgery or aesthetic surgery. Then we need to see what the patient require, where you need to enhance or volumize in which part of the face. And then you see which is the most important face where we look into, because the areas of animation, especially the lips and the eyes. So this anatomy and understanding how it works is very important. And the fourth comes what the patient wants. Many times the patient will say, okay, I feel that this is hollow, this is not hollow, so why don't you correct my right side, left side? But do not encourage this type of group what patient demands, because these are the patient, they'll keep on demanding, and these are very big distractors. So we should always try to avoid such distractors. So when we assess the patient, we should take a very good history. We should take a medical history, whether the patient is on a blood thinner, whether they have taken, usually to avoid all the G's before you go for the injection, where there's a garlic, ginger, and what we call ginseng, all the G's. So you take whether they are on the medicines and pills, especially when you inject Botox. You should not give patient on aminoglycoside any botulinum toxin injection, because they give the same symptoms as that of myasthenia. So you should avoid any patient allergy to eggs, any patient who are on aminoglycoside, any pregnant lady, any lactating lady. So you have to find out, you have to take a very good history. And the most beautiful face, when you try to maintain the natural curve, because you see, India is such a diverse country, and if you look to the people from different parts of the India, everyone has a different facial configuration. Especially in the northeast, we already have such a high cheek. So it is not advisable to do a cheek enhancement, especially when someone already, especially from Punjab, and if you see notice, people really have a very high cheek. So you need to do a very good facial assessment and always give a symmetry. And what is main aim of all this aesthetic treatment is that we want to reverse the age and give them a more youthful look. Because as we age, you'll see the jowls comes down because of gravity. Everything goes down. So the beautiful V-shaped face we have, it becomes and reverses, and the V becomes in a reverse direction. proportion. The front is, upper part is much narrower as compared to the lower part of the face. Like if you look to this mother-daughter video, you see the daughter has such a beautiful V-shaped, face, and the mother has a more of a squarish. This is because of the age, this is because of the gravity, and all these aging changes occurs because of the 4Ds, that is deflation, descent, deterioration, and the disproportion. So with this, I conclude. Thank you very much for your patient hearing. Should I finish my next talk on fillers and then I give it to Aditi? So basically the procedures that we commonly do, which I should say invasive procedure, is one is botulinum toxin, one is threads. I also do lots of threads because I feel that threads really have a very good benefit. Third is your dermal fillers. And fourth is the biofillers. Nowadays, you see the biofillers really have a very important role, especially the PRP and the PRF, and it really works wonderful. So today we'll basically discuss about the Botox and the fillers, but I feel that this, once you start your practice, we should always learn all these four, invasive procedures. Non-invasive procedures like the hydrofacial, the fat lipolysis, the HIFU, these are usually like when we learn physical, like most of the company people, they teach us like this is a setting you should do, this is. So once you buy the machine, you will know they'll give a different leaflet, they'll give you all the how the parameters to be set, the laser parameters, especially carbon dioxide laser, what needs to be set. But for this invasive procedure, you must have a very good understanding not only on the product but also about the anatomy that I have already mentioned. And we being oculoplastic surgeon, we usually work around the eyes, and what we do basically, we breach the hollows, and the most common hollows are either a tear trough defect here or a superior sulcus defect here. So what I want to show you here is that, as I have already mentioned, that you need the common hollows that we have is the tear trough and the superior sulcus, and we have a different types of the dermal fillers which Aditi will come in a better way. I just want to mention that we usually use the hyaluronic acid fillers, and the advantage of the hyaluronic acid fillers that you have an antidote to it. If there are complications, you can give a hyaluronidase and it will dissolve the hyaluronic acid. Nowadays in the market, Sculptra has come, that is the hydroxyapatite, that is Redicy, that has also come. And then we have the L-lactic fillers, these have also been come. But what is basically what we all of us are using is the hyaluronic acid. I'll not go much into this, but we should know what are the injection technique and the patterns. So once we start, the easiest is to go for the serial puncture. But when you go for the serial puncture, it is always you inject retrograde. So the chance of any of the vascular complication is much less when you go for retrograde. Second technique is when you go for a fanning technique. Fanning is definitely important, especially when you go for a tear trough filler, and sometimes for the nasolabial, or sometimes when you want to do a chin lift. So these are the great pattern of injection that we do. So, and the most important thing, you should know that what is the defect that we have the eye, and this very beautifully shown, which is a tear trough classification which has been given by Sedig et al., where they have said that type 1 is, sometimes you see very young people also, they have a small fat prolapse which we call it as a hill. Just below the fat prolapse, we have a depression which we call it a valley. And sometimes we have both the hill and the valley. You have a fat prolapse, then you have a hill below, very prominent. Sometimes we have a 2 or 3 layers of fat being prolapsed, and sometimes we have also the malar, hypoplasia, or the malar mounds and a festoon, which we call it a mixed type. But for publication, what we basically use is a Penck's classification, which is known as the ABL classification, which is based on what are the atrophy changes we have around the eye, what are the bulging changes we have around the eye, what are the laxity changes. But what is this tear trough? Tear trough is nothing. This is basically a separation of the palpebral part of the orbicularis muscle from the orbital part of the orbicularis muscle. When we look to the orbicularis muscle, we know one is the palpebral, one is the orbital. So here medially, the inferior medially, when the muscles start separating, which can also occur at a very young age, that is known as tear trough. It needs to be differentiated from this. This is an incorrect tear trough. This is the nasojugal fold, that is between the whole of the orbicularis from the levator alleganici muscle. So you should always start, because if you inject here, this will not correct the tear trough. And supposing if the patient doesn't have a tear trough and you inject here, it will lead to a big amount of lump and a bump there. So it is very important that you should know that where the tear trough is there and which the area you are targeting. Second, if you look to the different changes in the tear trough, this is not only the trough that is present, but also it depends on the depth of the trough. And this depth of the trough, there are now the 3D cameras coming up where they can measure the depth very well. And also sometimes you can also use the different software like ImageJ and all this software, where you can have a serial photograph and then you can put it in the system and then they can measure the depth. Secondly, the hyperpigmentation, which is very common especially in India. And third, the prolapse of the nasal fat, which you can see here. And lastly, all this wrinkles that occurs around the eye. So all this actually accentuates the prominence of the tear trough. So what are the 6 steps? So this is me when I was little younger. You can see this is the best way to evaluate the tear trough. When you do a tilt, you'll see you look younger. So you have to see whether there is a difference in the appearance of tear trough when you're in the straight position, up position, or in the downward tilt. Then you need to do a snapback test to see whether there is any laxity. Third, when we smile and then you see the fat is not there, that means it is an actual fat. Fourthly, you squint. When you squint, you will see the extension of the tear trough, and when you pull it, you will see the depth of the tear trough, and when you push it, that means you're pushing the fat. Here, very important point, that how to differentiate whether it's a fat or a fluid. You ask the patient to look straight, then ask the patient to look up, and then to look down. While looking down, if you see that a fat prolapse had disappeared, that means it is pure fat. But while looking down, the patient, you can see a swelling there, that means there is fluid. Based on this, you decide what type of blepharoplasty procedure you are doing. If you see the patient has got fluid also, that means if the patient looks down, the swelling is there, then you cannot end up by only removing the fat. You have to do a fat transpositioning, and you have to close that gap where the fluid is accumulating. So this is very important to assess when you plan for any of the surgery. So dermal fillers have got lots of advantages when we use it for the prominent tear trough. One, as I have already mentioned, that it, breaches the hollowness, that is the trough looks better. Like this lady, when you can see when she animates, when she smiles, you can see such a big trough. There's so much of changes in the skin texture only when she animates, and the best way is by giving a dermal filler. So the dermal fillers have got different concentration of the hyaluronic acid. Here I am giving a low concentration of hyaluronic, which is approximately 17.5 gram of hyaluronic. So you can use a cannula, you can use a needle, and as you inject it in the different planes along the tear trough, you see how she looks. This is how she looks. Now the skin texture looks better, and then when she animates, this is not with Botox, this is only with filler, and when she animates, you see the skin looks better, and also all the sagging changes in the skin is also not there, the wrinkles, because that has been all filled up by the filler. Thirdly, I have seen the tear trough not only corrects the trough, but also it corrects the hyperpigmentation. How? Because once you fill the trough, the shadowing effect is much lessened. So that is how you see the people with hyperpigmentation, they're very happy when you give the lower lid filler. So this is a lady, you can see she she's a doctor by profession. She has got so severe hyperpigmentation, and she's a very correct candidate for giving her a under eye filler. So there are different points which I'll come to you when we do under eye filler. You can go by needle, you can go by cannula. Here also I need to push the deep malar fat bed, so I'm using a needle technique, and then once this is being done, then I will use a cannula and superficially fill up the tear trough. So once I do this procedure, and you should know this, why I'm putting T1, T2, T3, you'll see, because these are some of the danger zones which will be coming when we do with the mannequins. So now when you look to her, if you look to her, this is how she looked before the filler, and this is how she looks after the filler. So as because the shadowing effect gets decreased, you see the pigmentation also looks much decreased, and she stays abroad at least once in 2 years. She will come only for her under eye filler. So this is also one gentleman. You can see how the filler conceals the fat. That is a small fat, and this is immediately post filler injection. You can see the fat is not seen. Another lady, you can see the fat, this is the site of the injection. On the table you can see the fat is much less following the injection procedure. So this filler in the lower lid, it not only fills the trough, it also decreases the pigmentation and also the conceals the fat, as you can see in this different patient. So how to inject? I usually draw a line along the inferior orbital rim, and sometimes another line approximately 1 to 2 millimeter below that, and mark the infraorbital foramina, and then a little bit of injection in the zygomatic eminence in order to lift the cheek also, and then you can inject into all the 3 points, that is one central, one medial, one lateral, along the line that as I have drawn. Like in this girl that you can see, she doesn't have so much of fat prolapse, but she is very conscious of her pigmentation and the little amount of the fat prolapse that has come to her, and this is the injection that I am giving her. And on the table, if you look very minutely, you will see the changes. The right eye where I am injecting, you will see just immediately after the procedure, you can see the fat is much decreased in the right eye as compared to the left eye. So it instantly you can see a definite change, and as the time goes, once it goes for tissue interrogation, it gives a much better result. So it can also be done by a cannula. Advantage of cannula is a blunt tip, and the product comes from the side. It is very safe. Vascular complication or the unevenness, the lumps, bumps, it is usually not there. So it can be done by the cannula, but always along the line that I have already shown you. So this is also another girl that I'll be showing. I'll go a little fast. Just with the needle, and before injecting you should be very careful. Once you inject the point, please aspirate, because you don't want to have any vascular complication. You aspirate, and how long do you aspirate? At least minimum 8 to 12 seconds. There are reports where they say 39 seconds is the limit, but I usually wait for 8 to 12 seconds. Aspirate and then you inject. So these are the changes that you see just before and after the procedure. This is with the Prilox, not a very good picture, but the advantage is you see the change from the negative vector to a positive vector. That is what we call, this also gives a much younger look. Another indication hollowing is the A-frame deformity that we have, that is the deep superior sulcus. I will not go much into it. Like you can say, this is the deep superior sulcus. Then with the cannula you can inject it, and on the table you can see that it really fills up. So these are the patient, like anyone practicing glaucoma, you will see after giving the prostaglandin analog, it really causes the lipodystrophy of the orbit, and because of it comes with so much of sunkenness. So these are the patient who does very well with the filler injection. As you can see, the lady, she is on the glaucoma medication, and this is on the table after the procedure, before and after. This is again another patient. She also has, it looks ptosis. This is not ptosis. Because of the deep superior sulcus, sometimes it gives a weakening of the aponeurosis, and after you put the filler injection, you see the ptosis also gets corrected. So this is a non-surgical management where sometimes in a deep superior sulcus we can also go for this. So this is another lady where you can see a very prominent A-frame deformity. This is because of the old age. She is quite old. She is approximately, I think, 72 to 75 years. And these are the patient where you really, they do very well. So this is also one of the indication where we, as an ophthalmologist, we can usually inject in the, periocular region. So when you inject, you have to really mold the tissue very well. And this, the product that I am using is a very light hyaluronic acid, so it will have a very good tissue integration, and within a week or so all these lumps and bumps will go, and you can see on the table a very good correction of the deep superior sulcus. This is this post-dermal injection. I have also injected little Botox here, so this is a swelling you can see. Just this is immediately after the injection procedure, and this is how she looks finally after a few weeks or after a month. And this is where she looks before and immediate after. And sometimes we also use filler for the brow lift. This is a very common indication, and this is how they look before and after. So these are some of the different indication to the periocular indication, but what today we'll discussing basically the tear trough. This is a very common. Why? Because it has got three major indications: for the hyperpigmentation, for the trough itself, and thirdly to conceal the prolapse of orbital fat. Sometimes I also use it. Some patient refuses the wrinkle treatment with Botox. I use the filler, And I'll just show, I'll go very fast. What I want to show is that whatever procedure you do, you should know little bit about the midface. So all these 5 points, especially this CK1 point, CK2, CK3 and CK4. This 5 is not important, it is very essential. CK1 point is a point on the zygomatic arch. CK2 is a point on the zygomatic eminence. CK3 is a deep malar fat pad, and this is a pre-tragus. So sometimes it is very essential that patient also wants a little bit of the midface lift. So this is like we're only doing a midface. You can see how the shape of the face, she looks much slimmer and much lifted following the procedure. So I'll just go fast here. So this is how we do a full face filler. And little nowadays people comes to you for the lip enhancement, and this is really one of the most in demand. It is not that you are giving volume, you are just making the lip look very fresh, and this can be done with cannula, it can be done with needle, and this is how the lips contour shape changes. You can see it's just giving volume. The same lip looks much, this is with lipstick and all, this is without the lipstick, it gives a much better look, and this is how also we do a lot of the lip treatment. So it is not that this they do not have complication. Every procedure has some complication, so you should be very careful while doing such case, because the filler is not a drug. Because when we call the drug like antibiotic, like Clevum, 625 milligram TDS. But here it is not an antibiotic, it is just a device. So everyone will initially have this complication. Either the volume is too much, or it is too less, or it is too superficial. This will happen in everyone's hand. When you start keep on doing and doing, then this type of complication will much be less. Tyndall effect is very common, where initially you will see, but there is a treatment to it, that you can use the Hyalase, that is hyaluronidase. But the most dreaded complication is the accidental intravascular injection, which I have already mentioned you. I have mentioned you about how you need to know the anatomy and how it happens this. And the most best way is that you always keep a filler crash kit. This is very important. Very recently, one patient in India was referred to me by a dermatologist. She had a filler injection in this glabellar region, following which she had gone for loss of vision. So immediately when the patient came to me, after a week's time, I tried giving hyaluronidase and everything, it did not work. But when I was in outside, I had seen a patient immediately after filler, loss of vision, she was kept in hyperbaric oxygen. Immediately hyaluronidase was given, steroid was given, and her vision has returned to 612. So for the beginners, I say that this 2.5 millimeter zone, I think you should not start it. Always start periphery. Midface is the safest. You will not have any complication, because everywhere you are injecting on the bone, only here subcute. So the chance of any other vascular complication is not there. Tear trough is lateral, 2 points are very safe points. Median may be a bit risky, but you can start with only the 2 points. So with this, I conclude. And what is the treatment? Hyaluronidase. For every 2.5 millimeter, we do around 10 to 20 units. What you do, we have, I think, 1,500 units in a hyaluronidase. So 1 ml, you dissolve it 1 ml. Add to another 4 ml of the normal saline, so 5 ml. So this will have 1 unit, will have 30 units. So that is how we do the calculation. These are fastest calculations. And then if you Hyalase it, all the complications vanishes, except in case if you have a intravascular complication. So this intravascular complication, it is best. That's why you should start practicing with a cannula. Till now, there are no case report of any vascular complication with the use of cannula, because tip is blunt and the chances of going inside the blood vessel is less, and also the product comes from the side, so you're not directly puncturing any of the vessel. So with this, I conclude. Thank you very much for your patient hearing.
Now Dr. Aditi Grewal will have a talk on the Botox, the side effects and marking.
Good evening, everyone. I would like to extend my gratitude to Disha Eye Hospital, Dr. Sabita Katoch, and Dr. Kasturi Bhattacharya and Dr. Joyita for having me here. I'm going to speak about one of my favorite aesthetic treatments, that's the botulinum toxin. The favorite part that I have about this is that it's completely reversible. So if you look at the history of botulinum toxin, it's quite old. In 1822, it was first isolated as a fat poison by Dr. Kerner. Subsequently, the term botulism was coined where there was systemic toxicity noted with the Clostridium botulinum bacteria infection. In 1973, the first published use of botulinum toxin A was documented by an ophthalmologist, Dr. Scott, for strabismus in rhesus monkey. In 1989, it gained FDA approval for blepharospasm as well as strabismus, and recently in 2002, it gained approval for cosmetic use for glabellar lines. So what exactly is this toxin? Botulinum toxin is a neuromuscular relaxant. It acts presynaptically in the neuron, where it inhibits the binding of the acetylcholine containing vesicle with the membrane protein by inhibiting SNAP25 or VAMP, vesicle associated membrane protein. By binding these two proteins, it prevents this release of acetylcholine in the neuromuscular junction. In the absence of acetylcholine, the muscle does not contract and thus the wrinkle disappears. There are multiple subtypes like A, B, C1, D, E, F and G, out of which A, B and E have shown potency in human beings, and A and B have been isolated because of long in vivo potency. They have been purified and prepared into a commercially available product. Type A is the most common, and this is what is commercially easily available. The term Botox per se does refer to one patented commercial product by the company AbbVie. The other ones include Dysport, Xeomin and Jeuveau. Within them, the particular protein and the additives are different. For example, Botox by the AbbVie contains onabotulinum toxin A, and the molecular weight is different. Compared to this, you have the Dysport, which has an egg protein and a milk protein with it, which is the abobotulinum toxin A. Xeomin, which is a pure toxin molecule without any peptides, is the incobotulinum toxin A. Coming to type B, we have the myoblock and the neuroblock, which is the rimabotulinum toxin B. These are more expensive and not that easily available in India yet. The ones highlighted in pink are FDA approved, while the others are biosimilars. What we must remember that when we are switching from one product to the other, whether it's a different type of type A or type A to type B, the doses are not numerically interchangeable. And when tolerance to one particular salt develops, we can switch to the other subtype of the botulinum toxin. Since B is not easily available, it's more expensive. So today's workshop will be limited to discussing about Botox, that is the type A, onabotulinum toxin A. Just to emphasize, the doses are not numerically interchangeable, so we do have some rough conversion chart depending on the product available, whether it's Dysport, Botox, Xeomin or Neuroblock. These are easily available online, and if you're familiar with one, the other you just need to convert and make sure that you know the doses are correct. There are more than 30 approved indications in the human body where Botox can be used, starting all the way from myoclonic disorders, strabismus, blepharospasm, hemifacial spasm, cervical dystonia, chronic neck and back pain, spasmodic dysphonia, focal spasticity, upper and lower limbs, pediatric cases, essential tremor, achalasia of the gastrointestinal system, bruxism, oculomotor paralysis, dysthyroid ocular myopathy, myofascial pain, and idiopathic overactive bladder. The workshop today is limited to our periocular lines, that is the wrinkles around the eye and the forehead. These include your forehead wrinkles and lines because of the frontalis muscle, your crow's feet because of the orbicularis, your bunny lines and your glabellar region because of the procerus and the corrugator muscles. Some contraindications that we must remember: absolute include motor neuropathies like amyotrophic lateral sclerosis and neuromuscular junction disorders like myasthenia gravis and Eaton-Lambert syndrome. Relative contraindications where the Botox can be deferred or delayed includes pregnancy. Any area of active infection or inflammation, especially for full face Botox, if a patient does have active acne on the forehead, I would like to delay the treatment till that settles down. Known hypersensitivity to any of the ingredients. In this situation, the Xeomin is quite popular because it doesn't have any protein peptide, so it has the least amount of allergic reactions. Systemic aminoglycoside use, because this can potentiate the systemic action of botulinum and can actually lead to respiratory arrest. And any bleeding disorders where you may have an option to stop the anticoagulants to avoid bruising, or you may counsel the patient that a little bruising will happen and can go ahead with the treatment. So coming to the reconstitution, I'll be talking about the product by the AbbVie company, that's the Botox A. So this is what a tray ideally looks like. You have your Botox, which comes in a ice pack. It has to be kept at 2 to 8 degrees. You check the box, you examine it, you see the expiry date, the batch number, and verify the seal. Then under sterile conditions, the Botox actually just lies as a powder on the bottom of the vial. Normal saline, preservative-free normal saline is taken in the desired amount depending on the dilution required. And then if you notice here, I am not pressing the plunger. The needle once inserted, it's a vacuum sealed vial, so this will take up the saline on its own, and this actually checks that the vial seal is maintained and it's not been tampered with. After this, I will gently roll the Botox vial in my palms without shaking it too much, because being a delicate molecule, we don't want it to physically disintegrate. Regarding the reconstitution, this is a desirable way of remembering what amount of normal saline you have used to dilute it. In my clinical practice, when I am using a 50 unit vial, I prefer to dilute it with 1.25 ml normal saline. If it's a 100 unit vial, I use a 2.5 ml normal saline. Why I do this is because when I am injecting botulinum toxin, I use the insulin syringe with a 29 gauge needle. And this has markings of 40 points for 1 ml. So when a 100 unit vial is diluted with 2.5 ml normal saline, I get a concentration of 40 units per ml of the botulinum toxin, which is equivalent to 1 unit per mark on this syringe. So then when I'm injecting, when I know that my reconstitution has been appropriate, every 1 mark that I inject, I know I have given 1 unit of botulinum toxin at the desired location. So this is a very comfortable dilution for spasms and functional indications, and this is what I would recommend you to start with. In cosmetic indications where we want to inject a lesser volume, we can increase the concentration by reducing the dilution amount, but that is for later on. There's one more concept of meso-Botox, which is given on the cheek and large areas for open pores and to reduce sweating. Over here, we do not want to paralyze the multiple muscles around the face. We just want to target the muscles in the sebaceous area, which is the erector pili muscles around the hair follicles, and here we give a hyper diluted Botox. Once reconstituted like this, we further dilute it by about 3 ml to get a very dilute dose of Botox. Storage, like I mentioned, it's a delicate molecule. Refrigeration at 2 to 8 degrees Celsius is mandatory for the Ona botulinum Botox as well as for Dysport. For Xeomin, it's quite stable, not having any protein. It's quite stable at room temperature even after reconstitution. Once it has been reconstituted, you should ideally use it within 24 hours, but studies have shown that if it's been kept up to 4 to 6 weeks, it has remained stable. Xeomin, once reconstituted, has shown efficacy even at 1 year follow-up in a controlled study, but this is something which I would not want to use an older reconstituted vial because of the potential risk of infection. One thing to remember is do not freeze. It's a delicate protein. If you freeze it, it loses its structural integrity and loses its potency. Coming to the dosage, when it comes to functional indications like spasms, for benign essential blepharospasm targeting the eyes, the usual dose is about 30 to 40 units of botulinum toxin A. For hemifacial spasm, it's about 15 to 20 because you're targeting only one side of the face or giving a differential dose. When you are using it for thyroid retrapel eyelid retraction or for epiphora in the lacrimal gland, the doses are quite low, less than 5 units of botulinum toxin. Now, when it comes to aesthetic, there are various guidelines available. You have a full face protocol, you have an upper face 64 unit, 80 unit protocol easily available on the internet. The recommended doses vary, but when you are starting out, it's good to start slow. You can always augment the dose, increase the dose on the next visit when if the desired effect is not achieved or the duration of effect is less. My personal preference when I'm using the glabella area, it's about 24 units. For crow's feet, it's 10 to 12 units per side. For frontalis, depending on the width of the forehead and the kind of forehead wrinkling, it's about 10 to 15 units. For bunny lines and the nasal flare, about 4 units. For a lip flip, where you just want to open the upper lip and reduce the gummy smile, it's a very low dose, 4 to 6 units. A higher dose here can impair the puckering movement and the patient will not be able to sip from a straw. Lower lip and chin, again be careful because you do not want to cause a drooping of the angle of the mouth, and stick to about 8 units. Masseter, where the cheeks are hypertrophic and you want to inject this, or even for bruxism where patients have nighttime teeth grinding, about 15 to 20 units per side. And for the neck bands, about 12 to 20 units while avoiding the midline. Coming to the markings, over here, the white cream that we note is an EMLA eutectic mixture of local anesthesia, which has good topical absorption and causes numbing. So this minimizes the pain of injection prick, although the needle size is quite small, but because the multiple pricks are given, it's good to always give a topical anesthesia agent. If you don't have this cream available, you can even use ice compression, which also numbs the pain. So the marking should be ideally done in a sitting position. The center of the pupil has to be marked, because when you are limiting yourself to aesthetic indications, you will always remain lateral to the midpoint of the pupil to avoid any complications like epiphora or injection into the lower orbicularis oculi near the tear gland. It's always good to ask the patient to animate. So here I'm asking her to frown and mark it, and the muscle is easily visible. The procerus and the corrugators are easily marked when she animates. The frontalis is a very variable muscle. It's supposed to be a V-shaped muscle, and there's supposed to be no muscle in the center of the forehead. So always ask the patient to raise the eyebrows to identify the deep wrinkles and draw lines into them so you can identify. Again, for the lower lip, I'm asking her, for the depressor anguli oris, I'm asking her to pucker her face so I can identify the muscle. And this is ideally the best way to mark your points, by making the patient animate. Coming to the injection. So the injections in the periocular area are supposed to be very superficial. You're supposed to form a bleb because you're targeting the subcutaneous area so that the injection is absorbed into the orbicularis oculi muscle. The skin is very thin. There is no subcutaneous fat over here. It's the skin, then the epidermis, dermis, and the orbicularis oculi muscle. So the bleb, when it's visualized, you know that you've remained superficial and the injection has not gone too deep. It's important, especially in the upper eyelid, because beneath the orbicularis oculi, then you have the levator muscle. And if the injection is too deep, you will result in inadvertent ptosis. So when the injection is being done, the non-dominant hand is always supporting your injection so that there is the needle is not free in your hand. You're always resting it against. Your markings have been done in place. When giving the injection, don't go through your mark, because then you're implanting that mark, the white mark or whatever color you've used, inside and causing an allergic reaction. You can go close to the mark, but avoid going deep into the mark. When you are injecting the glabella, you must always stay above the orbital rim, because any injection over here, if it seeps down, can cause ptosis. It's a good practice to place your finger for about 2 to 3 seconds after the injection to ensure that your bleb doesn't dissipate inferiorly. Avoid massaging the sides. Because I'm just applying an ointment superficially with the help of a bud. I'm not going to massage these blebs. These blebs will remain after the procedure for about 2 hours. You tell the patient not to touch them. These are desirable because this means that your injection has been superficial in the desired plane that we have wanted to inject. The results are very dramatic. This is after 2 weeks. So botulinum toxin A, the Botox product, shows an onset of action in about 3 days with a peak effect at about 12 days. This peak effect remains for 3 months and then starts washing off. That's the theoretical thing. In practical, the first time a patient is undergoing cosmetic Botox for wrinkles around the eyes, and if your dosage has been correct, like up to 10 to 12 per side, the effect actually lasts longer, up to 3 to 6 months in some situations. A lot also depends on the patient's physical activity. An avid gym goer will wash off the Botox quite frequently. A person who animates a lot, expresses a lot, will have a faster wash off. If the patient is taking certain medications like aminoglycosides, which can potentiate botulinum injection, the injection is actually contraindicated because the molecule remains in the body for a very long time and actually can cause respiratory arrest. Coming to some complications, the upper eyelid ptosis can develop, lag of ophthalmos if the orbicularis oculi has been injected too much and the eye closure is impaired. Functional epiphora, if you've injected too medially, the Jones muscle, which is responsible for the lacrimal drainage system, can be temporarily paralyzed, leading to watering from the eye. If your injection, especially when we are doing the lacrimal gland Botox, has gone too deep into the lateral rectus muscle, the superior rectus, it can cause diplopia. Eyelid hematoma can happen if the patient is on anticoagulants and if your injection has gone through a vessel and has caused a bruise. And infection, if the patient has rubbed that injection bleb site where the small prick has been there, used a makeup product or used anything without letting it heal, they can land up with infection. Most of these complications like ptosis, lag of ophthalmos, epiphora are reversible, and that is why it is one of the procedures of choice, because if something does go wrong, because the action is reversible, the side effect is also reversible. Post-procedure instructions include telling the patient not to lay down flat for about 6 to 8 hours, avoiding heavy exercise for up to 2 days, avoid rubbing the areas for 12 hours till the injection sites are sealed, avoid makeup, avoid washing face with dirty water for 24 hours. Any other aesthetic treatment like laser, ultrasound, peels, facials, or microdermabrasion should be avoided for a minimum of 2 weeks. If fillers are to be planned in the sequence, I would do my filler first and then do the Botox. Otherwise, if the Botox has been done first, at least a 2-day gap before I do the filler injection. And the patient has to be instructed that if there is severe pain, swelling, redness, or blisters, they have to report SOS. Soft tissue fillers, ma'am has already covered, but I just want to share one particular slide. So, ma'am mentioned that these can be hyaluronic acid, synthetic permanent fillers, which include the calcium hydroxyapatite, or the autologous, which is the fat, and now the platelet-rich fibrin. The filler, there's one terminology called the G prime, and this is something which whenever you venture and purchase a filler, this is one particular property that will be discussed. The G prime is the viscosity and elasticity of the product. It's a rating that how runny or pliable a filler is. A high G prime filler, where it's injected, when it's injected, it will stay there. Whereas a low G prime filler is fluidic, where you have injected it, it will spread more and it will wash off faster. So higher the G prime, the denser and sturdier the filler. If we look at the products by AbbVie, we have the Juvederm range, which is hyaluronic acid, which is cross-linked. We have the Juvederm Volbella. Then we have the Volift. Then we have the Voluma, and then we have the Volux. I have brought samples of these to show you what the syringes look like. The idea being that the Volux and the Voluma have high G prime and they are used on the bone to provide structural support. Where they are injected, they are going to stay there and going to provide a firm kind of a support. Compared to this, in the periocular region, which is a soft mobile area, you want a filler with a low G prime, that's like a Volbella. And also on the lips, where you want some kind of volume, but you want it to be mobile, you don't want lumps or permanent dense fillers to settle over there, you use something like a Volift, which has a moderate G prime. Tear trough indications have been discussed, and fillers can also have dramatic effect. For example, over here the tear trough and the scar has been treated. Over here the mid face has been treated along with the tear trough. Even though the nasolabial fold was not touched, there is an improvement from before in the after picture. Just by volumizing the lateral cheek and the tear trough, we have been able to treat the center of the face at the nasolabial fold as well. In this patient also, the tear trough, the mid face as well as the lateral cheek has been treated. The whole area has been volumized. Little bit of injection was given in the piriform fossa, but the nasolabial fold per se was not touched. And if you see from the before to the after, there is significant improvement in the nasolabial fold in itself. Crash cart should be ready, and hyaluronidase, ma'am has already covered that. That is a product which can reverse these hyaluronic acid fillers. But if you are dealing with calcium hydroxyapatite or even with fat fillers, that's the autologous fat injections, this hyaluronidase is not going to work there. Over there, the only treatment for any complication is to remove the filler surgically. Thank you for your patient listening. I think we can now proceed with the hands-on. So we do have some mannequins which in which we can inject saline to practice how to give the botulinum injections to get a almost real feel of how exactly you're going to prepare the product, how you're going to hold your syringe, where you're going to rest your hand, and how the bleb is going to form when you inject. And for filler also, we'll be able to do some practice on the mannequins, and I would like it if everybody does get a hands-on and gets to try and do the injection on them.
Branch of the facial artery, which is a branch of the external carotid. It pierces the cervical fascia, and all of you clench your teeth, and then you feel the masseter. Clench, feel the masseter. At the anterior border of the masseter, the facial artery comes in the face. Okay. So since it comes through this very deep layer, over here it is over the bone. And as this artery comes, it takes a very tortuous because the face becomes broader. So we need space for the artery. So the artery follows a very tortuous course. Okay. So it is coming masseter. This is a masseter. So it is piercing the masseter, anterior masseter. Then it comes to the face. So face. Yes, above the bone. And the end of the mouth, 100 I use a 3 cc syringe and I take 2.5. Very important.
As a bit of free lines, this come in small.
So from 2.5
10 ml apples of
each two branches. So
So reconstruction with normal saline.
So when you have placed the needle inside over here, don't press the plunger, let the bottle take the saline in itself. That is a surety that the vacuum seal is not been and then you gently roll it on your palms. There's no shaking the wire, there's no dropping the wire.
When you inject over here, you either be very deep or very superficial. And then after crossing the here, it gives a nasal branch, and then it becomes more notches and becomes very superficial. Here it becomes an angular artery. So angular artery is very superficial, which we keep on saying while doing a DCI surgery, right? So here it becomes very superficial for the artery. So which is the most important branch of the internal carotid is the ophthalmic artery. So again the rule of 2.5. So in the supraorbital foramina, it gives the supraorbital artery and supratrochlear artery. So these are the two major branches. Laterally we have the lacrimal. Okay. Then we have the superior, palpebral, inferior palpebral. Then you have a dorsonasal. So these parts should always be avoided for the beginner because you don't want to have a vascular complication. So one is supratrochlear, supraorbital, one is your lacrimal, dorsonasal. What we basically teach you today, the most easiest thing is to do a mid-face. Why we do a mid-face? Because while correcting the mid-face, it also corrects the whole of the complex. We usually divide the face into three complex, upper, mid and the lower. So the most important point which we call CK1. You just feel highest zygomatic eminence. So how do you know highest zygomatic eminence? Like if she looks here when the light falls, no? Light is falling here. Can you see? So that is the highest zygomatic eminence. Or if you say that it is not possible, if you draw a line from the tragus to the L out the nose, right? One line vertically from the lateral canthus, bisecting this line, draw a circle. The superior temporal region is the highest point of the which is known as zygomatic eminence. Clear? So what you do, you draw the superior temporal region is your zygomatic eminence. This is a very simple way. How much you will inject? 0.1 to 0.2. What is the product for the one? I'm not going to secondary, second question. So these two points are very important, which will practice over here. Then comes the tear trough. So this is a tear trough. You see the tear trough. Everyone will have a line here. That is basically the zone of between the palpebral part of the orbicularis and the orbital part of the orbicularis. If you look here, can you see like in her case, you can see this is a prompt. This is the tear trough. Can you see? So what I will do, I draw a line along the whole of the orbital ring. Draw another line approximately 5 millimeter below it, say in this zone. So the first point is TT1. Why it is called TT? TT stands for theatre. Very good. So you should know the three major points: TT1, TT2, TT3. TT3, even if you don't know as a beginner, it is okay. TT1, TT2 points are very easy. So you ask her to do draw a line on a mid-pupillary line. The point just lateral to the mid-pupillary line is your TT1. So this is, now you know what is the inferior orbital. You draw a line along the inferior orbital. This is how I do it. Okay, in no textbook it is written, but I've been doing it and I find this is the safest and the easiest way. Then you draw another line. Approximately 2 to 4, 5 millimeter below it, and you mark this as a zone. Then with one hand you try to give protection to the globe. You have to give protection to the globe. Okay. Then you have the 3 points. So if this is his pupil, you draw a line from the mid-pupillary point. Just lateral to it as the TT1. And just below the lateral canthus is the TT2. And just below the between the midpoint and the medial canthus, it is a TT3 point. Midpoint and the lateral canthus is a TT2 point. Is it clear? So basically you start with TT1, TT2, TT3. TT3, why it is called? It is a dangerous point. So it is coming as a last point. Even if you don't give, you just give 1 point, you will see a difference. So whenever you do a tear trough, always start with CK1 point. Secondary point, TT2, TT3, then you see everything gets lifted. The patient will on the table see the difference, and the tear trough not only goes oculoplasty, right? So it is very nice way to conceal the fat. Is it clear? So what I will do, I will just practice over here. So each one of you first do, you all draw and show me. First you all do this CK1, CK2, TT1, TT2, TT3. But you want how to inject. Okay, so before I go, let me start with what are the different, what I was telling, TT1, TT2, TT3, right? TT1, TT2, TT3, Aditi was mentioning about the G prime. That means we require a lower viscosity product so that there will be no lumps and bumps and it will have a good tissue integration. The best product is this Volbella. You can see it is pink in color. Okay, and this Volbella has a concentration of 17.5 milligram per deciliter. Clear? This is a low G prime. Second low G prime or mid G prime, this is a whole lift. This is violet in color. This is basically for the lips. It will give volume, it will give also freshness. The third G prime is a volume, that is 20. That is, it should be given over the bone. Correct? So CK1, CK2 you are doing with volume. TT1, TT2, TT3 you are doing with Volbella. This is 20 milligram per deciliter, that is 17.5. No, 15. This is 15, this is 17.5. And this is something new that has come. This is known as Volux. This color is bluish and this has got 25 milligram. So what we have basically, this is not a Juvederm product, this is a Restylane product. This is for the skin booster. This has got these, which will come in something like a green syringe. I usually prefer using Juvederm. Why? I used to use Restylane, Voltaren, different companies, but Juvederm advantage, the positive aspiration is very strong. In case you prick the blood vessel, you don't even have to aspirate, the blood will come in your syringe. Then you know you have to withdraw. I feel the safety of the product is highest with Juvederm. So what are the different products? One is a skin booster, I will tell you how to inject. It has, this is known as Volite. Okay? And what is the concentration? It is 12. Clear? The next concentration is 15. This is Volbella, pink in color. This is basically for teardrop. But sometimes if the patient says, no, I don't want volume, I need some freshness, you can also give in the lips, both the product. Clear? This is a whole lip. This is basically designed for the lip and the nasolabial fold. This has got 17.5. Clear? This is for lifting. So this is voluma. This is on the bone. This has got 20. Clear? And then this is what? This is Volux. This is only for your refinement of the jaw. This is 25. So basically what we'll talk each on the product. So this is the skin booster. So it has got approximately, this is not Juvederm, but this is also a skin booster from the Restylane company. So what it has got? It has a concentration of 12 milligram per deciliter. So how do you inject? Supposing I'm telling you, we should get some syringe and you should all practice. This is actual feeling, you know. You have syringe. Get some syringe. Let everyone. I think there should be a Visilon. Get the Visilon here. Can we clean this off?
If it's the 12, then is there a question that you have to aspirate some because it's low density?
It is very nice because this all the vacuum, the moment you inject, it comes out the body. But before injecting, always aspirate. And how long? You should aspirate minimum for 8 to 12. But recent literature showed that up to 39 seconds he or she was aspirating, and after that they found positive. But I'm sure it is not a Juvederm product. Juvederm, even if you wait for 2-3 seconds, in case it hits the blood vessel, it will come immediately on the syringe. So I feel for the beginners, it is a very safe product. So let us go one by one. Okay. So what you are starting as a beginner, you are starting with 1, 2, 3, 4 products. Okay. Or even if you don't do lips, at least 1, 2, 3. This is a very safe product for the skin. It really gives a very good texture to the skin, especially for the pores, those dry type of skin. And also it gives some amount of lifting because it has got hyaluronic. So what you do, you draw a line in the infraorbital rim. you draw a line directly up to this here, nasal area, then along the nasolabial fold. Clear? Then approximately 1 centimeter apart you divide the face and divide the face into multiple square of 1 centimeter, both horizontally and vertically. Here you don't go above here, you stay below. This is the zone. Then in every zone you should go just intradermal or subdermal. It cannot be subcutaneous or cannot be very superficial. If it is superficial, it will lead to small swelling, right? And if it is subcutaneous, it will not work. So how do you know that you are just intradermal?
40 marks.
If this is a bevel, no, you go 2 bevel inside. Because the epidermis will be approximately 1 millimeter thickness, dermis will be another 4 to 5 millimeter thickness. So if you are supposing this is the product, I'm telling you, you just go 1 to then inject, 1 to inject, 1 to inject. I have drawn all the 4 squares, no, in the center point of the square. So this is only for a skin booster. Is it clear to you all? Am I going too fast? So the basic, I think if all of you start with skin booster, you will not have, yeah, I will just draw it. Supposing this is the face, you draw a line like this point and this point, okay? Then you divide the face like this and you divide into vertical lines, right? Of 1 centimeter. Then again 1 centimeter here, vertically, right? Then within every point you give 0.1, 0.1, 0.1, 0.01, 0.01, 0.01. You will have almost 100 squares on your face because it has got so less G prime, it will just diffuse and it will just penetrate the skin. Okay, so it has at least G prime. Over here, you have to make the square very small. It should be half a centimeter. Same thing, just below the subciliary line, you draw 1 line. You already have this intraorbital line drawing. Again, make it half centimeter square, and between each you give a very less 0.01, 0.01, 0.01. Here again, the same thing. What I have this zone, you divide it into half centimeter. Correct? Half centimeter, and then you divide into half centimeter, same 0.01, 0.01, 0.01. So these are the point. Here also you draw all half centimeter, 0.01. Then this point you do not inject because we have the supraorbital, supratrochlear all coming here. Then this again becomes 1 centimeter, 1 centimeter. And you inject. Sure, all of you clear? Where you inject? No, 1 cc will have 1 ml. So approximately 0.01 means almost 100 points. Okay. Sometimes what we do, we take 1 syringe one side, 1 syringe one side. But 1 syringe also you can do for the whole face. It will cost you approximately 9 or 10,000 per syringe, and you can charge approximately 13,000-14,000 from the patient. So that is also affordable, 15,000 to over the whole face for each of the patient. Okay. So this is for which is known as Polite. This is known as a skin booster. Advantage of the Restylane, here it comes with a click. It does not come with a thing. Juvidum product. So every 0.01 goes on it, it makes a click. So you're very sure that 0.1 has gone. Okay. And what is the depth? Who can tell me? 2 Why? Because within that 1 to 6 millimeter we have the whole of the dermis. And if it is deep dermis, it is better. Why deep dermis? Because it is within the skin and there will be no lumps and bumps. Okay? And if it goes subcutaneous, then it is not working on the skin, so it will not give any effect on the skin. But every one of you can start this because it is very safe, no vascular complication because you are within the skin. Okay, this is number 1. Number 2, what we are supposed to do? We are supposed to do this. CK1, CK2 point. You just know CK1 already I have mentioned the point on the zygomatic arch. CK2 is the point on the zygomatic eminence, and this drawing I have given. So what is the product? The product is why we are giving on the bone. Another way when we inject, we usually pull a little. Why do we pull? Because we have the zygomatic ligament. And with age, what happens? Everything said, the zygomatic ligament comes down. So what we pull, if we pull and inject, that means you're pushing the ligament, that's why the face gets lifted. All the ligaments are interconnect, and these are the main ligaments, these are the pillars of the house. Like when we construct a house, we first do the pillars, then we do the walls, then we do the interior. Exactly the face is there. You target where the ligaments are there. That means you're correcting the pillars. Then the side by injection cartilage, and lastly this portion is basically interior. Like you do the lips, you do this, whatever you do, this is the interior. Is it correct? So you put the zygomatic ligament, inject here, zygomatic arch 0.1 or 0.3 maximum. Different ways of injecting, but for you to make it very simple, one bolus on the bone, you take the syringe, go on the bone, aspirate, then inject 0.3. Then the zygomatic evidence on the bone, aspirate 0.2. 0.5, bone, 1 syringe gone. Then here TT1, TT2, TT3. TT1 we inject how much? 0.2. TT2 we inject 0.2. TT3 0.1. So 0.5 goes here, 0.5 goes 2 syringe gone. At least start with 2 syringe. And if you give the skin booster, 3 syringe. So at least you should have a patient. If you do wasting, do skin booster and the facelift. That is cheapest also, that is only 2 syringe. And even the patient wants and only the lift, and you do the 1 syringe only, that is a volume up. So 0.5 both sides. Okay. So what we will do, we will now practice. Visilon, you have to Visilon.
So for the glabella, there are 2 ways this type. I prefer the perpendicular.
Skin, number 1 is for pores. Number 2, the irregularities. Like it gives a very good texture to the skin. Like collagen, they say that it helps in the collagen. Now everything has gone to collagen, right? People take collagen supplement. All this PRP, PRF, these are basically collagen supplements, and it really works good. If you unbiasedly ask me what is the best skin treatment, I'll say PRP. Nothing is above PRP. Skin, I'm only telling about the skin. All of you do 1-1-1. Your own blood only you are taking. Do PRP, you see the change in the skin. Nothing is above PRP. I'm telling you. But this also gives some amount of volume, the pores it takes. But PRP is best for skin rejuvenation. I do lots of PRP. Like once you start your practice now, you'll see like how the patient wants and the demands, and then you end up doing so many other things also.
Oblique here, deep, and oblique here. But the idea is that you
Meals also
He
there.
wants to get it now.
No, I want to know what's the indication of what you should do for me. So
Come,
that's
I
best
will
to know actually.
assess your face.
That's best to know, not I am joking.
Come sir, you come. I will assess your
What is
face.
it? I understand it well.
This is the clinical trial.
That I understand it well.
Volunteer.
You have volunteer. So if
Yeah.
you look also, you see, open the glass. So look at them, see that. What do you look? If you really look at him, he will tell you that I want this or that. He looks a little tired. Am I right?
just to blink flat and the patient is
Look straight, sir.
even dry.
He looks a little sad.
It is not as.
Sir, yes, sir.
Am I right?
It is less.
He looks a little sad. Looks sad. So you don't have to jump and tell the patient, I will look beautiful, you look. I will make you look more happy. I will make you look more rejuvenated. I will make you look more refreshed. You don't have to say, I will do this, take out the wrinkles. No. Sir, you're looking very little sad. If I make you look happy, your patient will be happy, you will also feel happy. Sir, you look so tired. But it is only the morning hours. So I'll do something which will make you look less tired. So use those type of words. That you are looking sad, you are looking tired. Okay? You don't say, sir, you're looking old. Or you that is not correct. No one will like, no, someone says, oh, Dr. Kasturi, you look so old. Even I will feel sad. No, I am old. Okay, even I will feel sad.
I'll feel happy if you tell me old, because I want to retire gradually.
It is true, old is gold. I also say. But
He wants to
when
look
you
like Rajesh Khanna.
okay. So while counseling, you always say, sir, I want to make you look happy. I want to to make you look distressed, like you are so sad and stressful. So that is what is it. So if you really look to here, so first let us see the upper face, then we see the mid face, then you see the lower face. So upper face, we just ask him to raise the eyebrows.
There are two ways.
So what you need, there are two things you need. One is definitely the wrinkles. Secondly, normally young forehead is always a convex, but he has a flat. But at this age you cannot explain it that I will make a convex. Supposing he's young and you see a flat forehead, then you can also tell, sir, your forehead looks very flat. Flat is a sign of aging. I can give little filler on your forehead and it will give a convex, because convex forehead is a young forehead. Just I'm telling you. Then you can tell, sir, you have got so much of wrinkle. I will not decrease the expression line. I don't want to, frozen face, but I will just reduce some of your wrinkles. When in the Botox session, I think when you do, since just coming here, when you inject for the wrinkles, always ask the patient to look. So look up. Then you draw the line. This is the last line of wrinkle, correct? Ask the patient to look straight and draw a line to the mid.
You have a narrow forehead.
Here,
Hardly.
then you draw a V.
maximum.
Correct? Then basically you are supposed to inject only 5 points, because you don't want all the wrinkles to go, because it will not look good. So inject in the form of a
Some people do not have lines in the center. I have significant lines in the center. Some people just have lines in the center.
Clear? It should be in the form of an M. Patient, even Shah Rukh Khan and all, no, you see that's why their expressions look so good. You need some amount of expression. It doesn't look good with all this frozen thing. So the M is the best technique. That is called rule of 64. What is this 64 points for the Botox I'm telling you? Though we are supposed to speak filler, so 20 units you are giving. 4 into 5 points. Correct? Then you ask him to frown. Sir, you frown? See? You need to treat his frown lines. So when you treat, you inject into procerus. Here, this is the procerus muscle.
Sometimes what happens is one
In the procerus, inject it 4 units. Then when he frowns, you use it. This is where your forehead is ending. You can see.
I maintain a
Okay. Ask him to
and I
reach
have
it. This is a medial and body. And this is the tail. This is the body and tail. So how many points they have come? 5 points. 4 in each point. So 20, 20, 40. Then there should be, you draw a line either this way or in the form of a curve. So first point, just 1 centimeter lateral to the lateral canthus. Second point below, third point below. So 3 points you are injecting, 4, 4, 4, 12,
Pricing.
4, 4, 12, that means 64. Why I am telling you, suppose if the patient can afford, if you do 64, it is very good. Every muscle has got an antagonist, right? So what happens, or a muscle which works in a they always say upper face works in a complex. If I treat only this forehead, this will become very prominent, because it is antagonist to the forehead. The only elevated eyebrow is the frontal disc. Rest are all antagonists. These are all the depressors of the eyebrow. If you treat only this part, this becomes very prominent. They will say, oh, my this is format from Delhi is a little less prominent. So you need to treat it as a complex. So 20, 20, 12, 12, rule of 64, and they really look very nice. You are treating the whole of the upper component. So this is basically what he needs. He has got little amount of fat prolapse. Like if he comes to me, I'll say do surgery, I'll do blepharoplasty, because I love doing blepharoplasty. But he says no, I will not do surgery. Then you have filler as an option. So draw a line along the inferior orbital surrounding. Another line is 2 to 3 millimeter below. You can use a cannula, you can use injection. I'm teaching you only the injection technique. So ask the patient to go straight. Just lateral to the pupillary line is T1. Then between this, mid pupil and lateral canthus, on almost at the reverse, you have the TT2. Mid pupil and median category, this is TT3. What it does, actually you see the conceals the fat. No one asked me that how it conceals the fat. When I inject here, we have the orbital septum. Orbital septum is in the inferior orbital rim, right? And when we age, the septum becomes flexed. So the fat becomes prolapsed. So when you inject the filler here, it pushes the septum. So once the septum is lifted, the septum will push the fat inside. Can you understand? That is a very basic understanding why we have a concealing of the fat. It stays approximately, filler actually doesn't. The activity stays for a year, like 1 year, 2 years, whatever, but you know, it never goes from the body. It might go after 10 years, but I have some filler patient almost 3 to 5, 6 years for theatre, still they look so nice. So when the company says the action, they never said that life is for 1 year, they say action is for 1 year. That is the action stays, that is they will say. But there may be some amount of going in, but whole it never goes.
Have you ever repeated filler also?
But some patient becomes addict. Pura addict. Because I do lots of filler for those patients, supposing for ectoblastoma, they do a ball implant, eyes remove bolus, and they come with so much of like sunkenness, no? Even the day before yesterday, I had done 3 patients like this. You inject filler, it gives volume, it comes so nice. There are lots of other indications for filler. Late retraction, they don't want to undergo surgery. Inject filler, this is stretching, no? Slowly you see the late retraction comes good. So there are lots of functional indication for filler also. So filler, it has gone down. But for cosmetic, we say about 15 pills. If you want to symmetrize the face, leg of thalmus. If there is a leg of thalmus, we use gold implant. But if the patient don't want to do surgery, very old patient, then put filler. That will use as a implant, which will heaviness curtain. For exposure keratopathy, many people use filler. Even for thyroid lid retraction, we go subconjunctively inject filler. So there are lots of functional indication also. It is not that you are only using for the cosmetic. Equal number of indication.
Very valid point. You would never tell
like Botox has got so many. All of you start with functional Botox. Next, when I will go to the Botox section, all of you start with functional Botox. If you do functional Botox, it's same like cosmetic Botox. If you do blepharospasm, and actually all of you should do blepharospasm. Anyone, whether it's a pediatrician, retina specialist, anyone, because blepharospasm is so common. Facial spasm is so common. So if you do functional Botox, it is like doing cosmetic Botox.
What niacinamide is.
So this is secondly we are treating his theatre. So I want to lift his face.
We do see skin.
See, the moment I lift it, he looks so young. So what I am so open the mouth.
Dermatitis, we see acne.
Close.
In general also.
See, this is his suture. I can feel his suture.
Periocular dark circles.
Then just interior. Now I am pulling my zygomatic ligament. So by pulling, I am injecting into the zygomatic arch.
Learn a little bit about these terms.
Zygomatic arch. Then I make your face like this. And see, the light is nicely following it. There's a prominence. Or if I don't get, then I draw a line like this. This is the part. Okay. This is a cicatrix. Cicatrix is a deep mallet. It is sometimes called a Christos angle. I'm not going to deep into it because it will be too much of confusion for it. Cicatrix sometimes we give, you can give, you do not get. Sir needs, because sir doesn't have a very prominent maxilla. So you can put a cicatrix directly on the bone. Clear? Cicatrix, this is the pretragus. This is a cicatrix. Cicatrix.
So my centrifuge when I boil it is what for making.
This is the pretragus. This is pretragus. And this is CK5. Sir has got good CK5. You don't have to inject. Okay. So you give CK1, CK2, you can give CK3. CK4. This face will be lifted like this. I'm not talking about the lower face, so this is what.
Yes.
So if I lift him up like this, I think with all the wrinkles gone, will he not look less sad? He'll look more refreshed, right? Am I right?
You're building your practice.
So that is what. So you have to tell him, don't tell him, oh you look this, I'll make you young, something. With the females you can play around, you can tell, but the males will not like it. They say, sir, I'll make you look very fresh and very rejuvenated, very happy looking. That is how we deal with the patient. Equally male comes male. I think in my place, most of the IAs, the actors, the ministers, all these people they come. These are some real high profile. So once you start doing, you'll see the patient. In a hospital, we are not allowed to do any advertisement. We are not, no advertisement. Even the name of the hospital is not there. It has been given by the government later. But I put Insta post now. And through my Insta, many of the patients are coming. So Insta is my own account. So I put something on the Insta. And that will teach you. But if I teach everything today, it will be confusing. So today what we are concentrating, upper part Botox. Okay. I have told you the rule of 60, 64. That is the whole this part Botox, and we'll do the fillers. And 24, 20, 20, 12 for younger people, like I was saying, 30. So you give here. They want then corrugator 2.44. They want that 4. The body is very big, deep into the bone. The tail is very superficial. You can get substitute. Okay. So 4, 4, 4, 4, 4, 20. Because they want 4, 4, 4, 4, 20. 4, 4, 40 units. So this is 24, this is 20, this is 20. It really gives a very nice look. And patients are really happy because you are targeting the whole of the upper face. And let's go to the filler. So since we don't have Vicinol, we'll have to take this. And one by one of you do a CK point, teardrop point, CK point, teardrop point. Then you will understand. Okay? Joyita, you start. You want to do CK point or teardrop? And that is you just draw whatever I told you, you just like now she is a teacher. So if you keep on telling, then you will remember.
That's very good. But actually it is not so. And in fact, like I belong to a village, so I've seen village ke shadis mein people are much more exotically dressed because they managed to order
Or how do you do it?
Ella to the triangles and there is straight line from the lateral
limbus, the lateral canthus
down straight. This is the cross.
It is 90 degree. 90 degree will not be, it will be something like this, right? Because the line is slanting. This 90 degree will be something like this.
Okay, this one.
Then you draw a circle there and the superior temporal point. Okay. That is a CK2 point.
Another is CK3.
It's a deep malar fat bed.
It's the deep malar fat bed.
it has the patient details.
Then you draw the fluid. How much you have to tell, how much you are injecting?
Here, 0.3.
You inject. Deep down. How are injecting? Is it correct? No. What? She needs to pull the ligament. You pull the ligament and always give some support. Then you inject. Once you inject, then you aspirate. 1, 2, 3, 4, 5, 6, 7, 8. Till 8, supposing nothing has come. Then don't shake and come like this. If you want to bone, it should be on the bone. Then 1, 2, or you can give maximum 3. Okay. Then you take it. Okay?
So once we touch the bone, we retract the bit or we...
Don't retract, give it there only. Because if you retract, if it comes too superficial, tendon effect will come.
Batch number,
Pull nicely, pull the one hand pull the ligament. Give a support. Support somewhere.
whatever works in your
This is single.
This is not recently there was a recall of someday if there's a recall
for
of
8 seconds minimum.
which patient got it, you could do a call back. Even though it's aesthetics, the doctor's
So
first.
be done, then hold it. One thing, if you can just if you can aspirate and inject with the same hand, it is better. But we don't, this is by the what they do, they aspirate and they inject with the same hand. That is, it becomes easy. But whatever way you are convenient. Okay?
Actually, this is smaller. I'm holding this.
No, we can put the needle, put the needle here. Put the needle.
Definitely practicing 3 times. You will be practicing something like that. And I want you to practice the belly region and the nose region. Frontalis, yes, these lines are but at least get his hands on one injection.
Then we stop till the blood stops. Then you throw off the discard where the blood is. That little bit you throw it off.
You can use air
Okay.
or line.
And then you can re-inject.
Well, in case if we need to hydrogenate, we will hydrogenate at the same point.
Around that point.
Around
Not
that
the same
point.
point. Around that point. Okay?
In the other one, I think it's and the needle for going to have the
Huh? Same 30 gauge needle.
1 point.
This 30 gauge needle. Okay. So next you will get teardrop. You draw. No, you draw the line in front of vital rim. Then third line. Mid line vertically.
First one is confidential. So I'm getting 10 vials. I'm done together. 8 vials, 8 vials. जब मैं अच्छा बना होगा मैं बाकी में फ्लूइड होता है. No, I don't. After DRC doesn't matter. Easy to practically change because that membrane. I am not sure how
We have to see a patient. The injection is given. On a live patient, we have to see it once. We have to see what is happening and follow up with that patient.
I think it's like okay. So we go back to.
Everybody in our it's okay.
We've loaded saline into this. You can even inject with air. With the air, the bleb will not form so much. If you're injecting saline, the bleb will form. But just squeeze it out. Don't let the saline remain. Whereas tomorrow in my suitcase it will. Today also at 45 minutes at Delhi airport, I had to explain why I'm taking a
He'll stop you at the security point.
I'm doctor. I'm like, thanks.
First, you have not murdered anyone.
They're very realistic. They're very realistic. I was looking for that 100-unit vial.
This they allowed you in the cabin?
खोल के दे दो
I don't know to check them. They're quite expensive. I don't want to check them. So this is 1.5 lakh. This one. Other is 80,000. They are very, very expensive. They
Because real feel like
are
soft.
imported. There's a company Archidermia, and they also make all kinds of. They have a bigger model which has all the layers, the bones, the fat part, the muscle, and everything. So they are grateful that I can use them for everyone to learn. But yes, they are. So Botox, the product from Allergan, comes in 50, 100 and 200 unit vials. So the 50 unit vial is like 150. These are used vials, but just to give you an idea what they look like. So on top of this there is a plastic sealing cap. The vial actually looks empty because the Botox is in the form of a powder just along the inferior rim of the vial. So the first time you see it, you may get confused. Khali sheesh name. It's a powder form, lyophilized just on the inferior. Delicate molecule, not to be frozen but to be kept in the cold chain 2 to 8 degrees. So if you are getting it ready for your patient, when it comes from the store, from the refrigerator, it comes in a thermocol box with an ice pack. You have to maintain the After that, once you have loaded it also, before you inject, these are placed on the ice pack. These precautions have to be taken to improve the efficacy of your injections, to avoid loss of quality of the injection. So when the vial comes to you, you will wear gloves, do it in a sterile condition. You will take a 2.5 cc syringe, and I prefer to dilute 50 units with 1.25 ml. That gives me 40 units per ml. I prefer this because the insulin syringe has 40 marks. So once I have made this dilution and loaded the syringe, every time I'm injecting, I know if I've moved 1 point, I've given 1. When we give a bleb of 2 units, the circle of diffusion is about a centimeter. So where I've given the injection, it's going to act in a 1 centimeter zone around it. If I'm giving 4 units, the diffusion will increase. The depth will also increase and the zone of diffusion will also increase. So 2 units at a point is a good enough idea because then you know where you have injected, wahi action de raha hai, chances of complications are less. When you reconstitute it, you have saline in this measured quantity. Preservative free normal saline comes in the small 10 ml ampules. You will put this in, but you will not press the plunger. It goes in on its own because it's a vacuum sealed bottle. This point is applicable only for this particular product, Botox. For other products like Dysport and Xeomin, you have to press the plunger because they are not vacuum sealed. Once you have done this, you keep this, put the needle on the side and then you gently roll it. No shaking, no doing tuck, 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 tuck. Just gently roll it. Again, it's a delicate molecule. We are talking about 2 to 8 degrees. That 2 to 8 degrees is not in your clinic. From where you're purchasing also that matters. From where they're importing also that matters. Whether that cold chain has been maintained. Gentle rolling. In the time that you've prepared it, then you will take your insulin syringes and start loading them. So we say up to 3 to 4 pricks with one needle. The pain is not there. Then the needle becomes blunt. So if you are giving about 3 to 4 pricks and each prick you are giving 2 units, so load up to 8 to 10 units only per syringe. It makes it more comfortable for the patient. This is not a rule, you can load 40 and keep injecting, but the patient will develop pain. And for the delicate eyelid skin, I always say right ke liye 1 syringe, left ke liye 1 syringe. And 1 syringe I use for the central area, glabellar area, and 1 for the crow's feet. 4 syringes is the essential retrospective. Before you start loading it, good idea to clean it with an alcohol wipe because it's a sterile product. You had opened it, you had injected, you had used the needle to plunge it in. You can clean this with an alcohol swab and let it air dry. And then start loading and prepare. Once these are loaded, then you go back on the ice pack. While this is done, what has happened with the patient? The patient has come to you. The patient has either come for a functional indication like a blepharospasm and has asked for a Botox, where you have examined both sides. You estimated that he needs on the eyes about 10 units per eye, that's 20. Crow's feet, 10 each side, 40. Glabellar area, another 20 units, 60 units. You've made your plan. Could be 60, it could be 40, depends what your plan is, and you've decided. For a cosmetic patient, they've come, they say, I don't like this particular part of my eye, so I want this area to be. You've done your discussion with the patient, told them what is realistically achievable. Some people come and say, Botox brow lift kar do. Botox brow lift is a misnomer. It can give a little change in the appearance of the eyebrows, but it's not going to magically lift your eyebrows. For that, you need threads or you need a face. So you've made your plan, you've decided I'm going to treat this area, I'm going to use this much units. Only then you will get the vial. If you're using 70 units for the patient, you get 100 unit vial, you get 200. Then comes the consent. Consent form for all aesthetic procedures, whether it's a PRP, whether it's a chemical peel, whether it's your Botox, whether it's your filler. At least in writing, it has to have every single complication, including risk of blindness with fillers, risk of ptosis, risk of lack of calmos, risk of dry eye, risk of epiphora, everything with Botox should be written on it. It is your job to explain to the patient, but you don't want to scare the patient also. So when it comes to Botox, I always use the line that if any complication happens, this product is reversible, so the side effect is also reversible. There's a good idea to have a patient input option on the consent form, where they select yes or no, whether they are on anticoagulants, whether they are allergic to egg proteins, because this sport has some egg protein in it and you need to for that. Whether they do more than 6 hours of rigorous weightlifting a week or something, things like those which make sure that the patient has read the consent form while filling it. I always have that one line, do you consent for patient photography? If they have not ticked no, then I automatically assume it's yes. But having that patient input form is for safeguarding. Botox के साथ कोई major complication नहीं होने वाली है unless patient has not disclosed aminoglycoside use. We know of a celebrity who underwent full face Botox while taking aminoglycosides and developed myasthenia gravis. Amitabh Bachchan, he underwent a cosmetic Botox and he was already on aminoglycoside in antibiotics and he developed a myasthenia-like syndrome. So that's a rare situation. But Botox के साथ कोई ऐसा major complication नहीं होगा which cannot be handled or counseled for. But having that consent form safeguards. The patient gets a cosmetic Botox. You promise 3 months के wrinkle चला जाएगा. The patient is a weightlifter. 1.5 months पे वापस आके कि doctor you took 30,000 injected 70 units but my wrinkles are back after 1.5 months. Then you see his consent form and say you've been doing weightlifting. Your basal metabolic rate is high. So this is for safeguarding yourself and for educating the patient and establishing. Patient also understands if you're doing something logically, you are probably a trained practitioner. You know what you're doing, so they trust you. Consent has been taken. Then you are going to use some kind of an anesthesia. So what I had shown in the video, the patient had white cream on her face. So I use a topical local anesthesia, which Prilokin, it's like a Lignocaine variant, which has a good topical absorption. So it's a eutectic mixture of local anesthesia with good topical absorption through intact skin barrier also. One mistake we often do is when we are applying it, we clean the patient's face with a saline gauze, then we remove all makeup and every patient will come in with a lot of sunscreen or some kind of product on the face, clean all of it. And then you take your finger and you start applying the anti. Your finger will be numb by the end of it. So always wear a glove or use a Q-tip or earbud to apply it. So that is a practical thing. It does give you numbness. With Prilox, you are going to feel cold sensation when you apply it and then a tightening sensation. That's what you explain to the patient. In spasm patients, I do not use the Prilox on the eyelid area. I will put it on the glabella, on the forehead, on the crow's feet, everywhere else on the cheek, but not on the eyelid because they keep doing this. And the Prilox will go inside there and cause burning sensation. So that is a practical thing. Over there, you can give them icing. You can do cold compression to numb the area. The injection is discomforting rather than painful. So Prilox takes about 25-30 minutes to show its effect. After an hour, its effect is gone. So they say you can no prick and Prilox too. Prilox, no prick and Prilox. Prilox is more expensive and no prick भी है थोड़ी cheaper. No gain, no pain, no gain ऐसे भी आती है. बहुत सारे नाम से आती है. So it has to contain the EMLA mixture. That's it. And people say that on broad areas you can even apply a cling film to keep it tight and have its additional effect. On the face I find it cumbersome to apply it. You can try if you have the cling film available, you can put it, but usually it keeps coming off. 20 minutes is a good enough time. In that much time you have gotten your Botox, you've prepared it, you've gotten the consent in order. I keep a register when my Botox is used, what batch number, what expiry date, what manufacturing date, what barcode number is there, which is a 50 or a 100 unit vial, what dilution have I used, how many units I'm injecting, and the patient details, so that if ever there is some recall of a batch, I know which patient to call back and tell that. Anything can happen, and it's a good idea. This advantage of this is that if I have a 100 unit vial, I've only used 70 units, 30 are pending. At least in my register, that log keeps on coming. At 1 week, it will give me a reminder that you have 30 units Botox, which will go bad. So keep in mind when you're having the next patient, you can use it. So it's good to have a record of all these injectables. Even in the OT, we have a record of every anesthesia injection that we do. Everywhere, it's everywhere. Intravitreal injections, we keep a record. Yes, yeah, go on.
Time for ice.
So ice cannot be kept continuously. So you can give them 2-3 minutes maximum they can keep, and you can repeat after 5 minutes. Give it again till you are preparing and getting the other areas numb with the I do it in the slit lamp chair with a slight recline, so I am ergonomically comfortable. Upright patient, I'll not be able to inject. Completely supine, I'll have to hunch over the patient, so slightly. I don't prefer laying down, then it distorts the face. Even for filler, it should be in an upright, because when you're laying down and you take a picture and when you're sitting, your sagginess comes down. Gravity effect will come down when you're laying down, so you can't have a realistic assessment. If I'm recording also, then I'll make sure that the lighting and the background is good. If I'm recording a video, I'll try and make sure that the background is dark. Any pre-picture that you want to take before the Prilox, because the Prilox has a numbing and a cooling effect and it has a sheen to it, the wrinkles may not appear so good, so deep. So all your photography, if it has to be done before you put the Prilox in. And in the same lighting as to what you're going to be doing for the post picture. For Botox, post pictures will be taken after 2 weeks because the effect is not going to come so soon. Filler you can take. So consent is signed, patient is prepared. Now comes the marking. So when you are starting out, always mark. When I am doing a new region, I will always mark. It's good to have the mark. A spasm patient will tell you where to inject because they're coming with that spasm. They have animation. This is sin kinesis is happening, so you know where to inject. You will see it. In a cosmetic patient, you can ask them to animate. So if somebody comes with forehead lines, you ask them to animate. So I have lines through and through. Some people have lines only on the side, some have only in the center. So you mark those and you can mark the lines. In the forehead, you will not inject in the depth, you will inject in the bulk. So you can mark your points. For forehead, usually keep 2 finger breadth above the eyebrow so that you're not inducing any ptosis, false ptosis. A lot of people are using the frontalis to keep their eyelids open. And after you give the Botox, this comes down and then they start feeling heavy. So brotosis can happen. So 2 finger breadth above this. Depending on the width of the forehead, I prefer 7 or a 5 points. So more points in the hairline, lesser points. So 1 point in the center, then up, down, up, depending on how many points you want to inject. For women, we don't go lateral to the lateral canthus because we like to have a little lifting effect here. In men, if you do this, it leads to a Spock deformity. The eyebrow becomes like this. So in women, you can get that arch by avoiding this point. In men, you should treat till the at least visible wrinkles in the periphery, but don't come below the. So you have the superior temporal fusion line over here. You can actually palpate that line in thin patients. So it is where the temporalis fascia fuses with the glia part. So that fusion line, don't go below it in cosmetic Botox. And you've just marked your points here, then you ask them to frown. So for the procedures, classic pattern is 11, 2 lines over here. That means the same. Some people have a deeper one, you can inject 2 points also. Some people have an X pattern, some people have less of procedures, more of these horizontal lines over here. So you know that you have to treat a little further down where the lines are coming. Some people have an omega pattern. So it's good to make them animate and choose your points of entry. Yes. So I would put one in the center and I would increase the dose for the corrugators because this is the corrugator coming in. This is the procedures. This is the corrugator coming in. So I would probably put 4 points here, 4 here, 4 here, 4 here, 4 here, 20. That's what I would.
I need
5 tricks.
Yes. In aesthetic medicine, nobody needs anything, they desire. You will not tell the person that you need it. That's why I said sorry to you that one time. If they come to you that we want something, then you can say that this is what I can offer you and this is what you can realistically expect. If somebody is asking you point blank, doc, how do you think you can make me look younger? Then you tell them, this part can be treated. But usually these people will say, ye chahiye.
Desire is the
Desire. So you've made your mark in the crow's feet. So classic is a fan pattern where you have one horizontal line here and then one above it, one below. This is your radial orbicularis oculi muscle contraction. So this pattern is there. Some people have just an inferior fan, a horizontal line and lines below, and some extending all the way under eye area. Here you have to be very careful. If you're too deep, you'll be injecting the zygomaticus major, and then there'll be drooping of the angle of the mouth. That's a happy muscle which lifts the angle of the mouth. That will start. Then if it's a functional patient, then for the pretarsal orbicularis, you stay 1 millimeter from the lash line because you want to inject the pretarsal, which is causing the forceful closure. You want to avoid the preseptal part, otherwise it can go deeper into the levator muscle. So the marking usually that I follow, I use a 5-point marking. I keep my medial point in line with the nasal limbus, superiorly and inferiorly. Lateral point in line with the temporal limbus, superiorly and inferiorly. 2 units at each point. And the third point I gave is just at the lateral canthus, very superficial. Other people keep 4 points, 2.5, 2.5 at each unit, or 2, depending on the amount of spasm in your. When the patient has come first time for a spasm, you want to keep a lower dose, you want to see the effect. When you are treating the pretarsal orbicularis oculi, you are inducing a little bit of lid lag and lag of thalamus. This is more noticeable in hemifacial spasm patients because they'll, after the treatment is done, they'll come एक side पे blink नहीं हो रहा, slow हो गया है blink. The Botox is going to paralyze the muscle. Spasmodic muscle, it is also going to paralyze the normal action of the muscle. When it's done bilaterally, sometimes it's not perceived. I usually do add a tear lubricating agent. Most of these patients are already on tear lubricating agents. I'll add a gel after the Botox is done for the initial 6 to 8 weeks at least. But when it's done on one side, they do come in with a little bit of lag of thalamus and link lag. So you have to be aware about it. That's kind of an unavoidable side effect, but it should not lead to an exposure keratopathy. So if they are coming to you, increase the lubrication. Tell them to start squeezing a little bit again, and it will get better. Botox side effect will always get better because it's completely reversible. So that is. इसमें I do meso Botox and whole light. So in the lower lid, except for a spasm patient for cosmetic, I will never inject medial to the mid-pupillary plane. So a lot of people have wrinkles here. Even I have wrinkles here. So you treat those with fillers or with Botox a little bit. But avoid Botox in this area. Otherwise, you will cause complications like epiphora and eyelid malposition can occur. When you're besides your spasm, sometimes when the involutional entropion is just setting in, it's a spastic kind. When you do the test of invoking entropion, if the patient squeezes and the eyelid goes inside, in those cases also up to 10 units are given, 3 points in the lower lid to reduce the chances of entropion developing, and that works. That does work. It prevents the surgery requirement in the long term. So you have made your points. So when you have marked your points and when you're giving the injection, it's a good idea to inject slightly away from the point so that you're not taking that marker, whether it's a sketch pen or an ink or this thing inside, because any foreign particle will induce an inflammatory reaction and then you'll label it as allergy to Botox, whereas because you've done your marking, your Prilox has been cleaned. I clean the Prilox again with the saline balls. Then I clean with alcohol wipes. Tell the patient the sanitizer just smell like it, because that's a strong smell, especially in the pre-tarsal area. Avoid it going inside the eye, so be very gentle and superficial, because even when it goes onto the eyelashes and the patient blinks, it can cause corneal. I actually don't put paraffin, I keep refresh tears ready because the patient will not tell me each other. There are two ways of it. So in chemical peels we never give paraffin because वो चला गया तो पता ही नहीं चलेगा. इसमें भी I keep refresh tears handy, and that fume also is kind of bothersome. So if the patient is prepared, they understand that yes, that smell is going to come. It's a alcohol wipe has a strong smell. When you've wiped, if your marking has gone away, then put the mark again and then wipe again. I'll even wipe when I'm switching from one side to the other because my other hand has touched that face. My hand is resting here, then it's going on to the injection side. So you have to maintain your as much as asepsis as you can in the OPD setting with Botox. A part of this is a glove choice also. Sometimes people use the non-sterile gloves, but it's for your patient safety, it's better you use the sterile gloves for preparation as well as injection, and the time interval between preparation and injection is usually 20 minutes, so change the gloves because you may not have realized that you've touched the marking pen. You put the mark with the gloved hand and glove is no longer sterile. So at least, I mean, be mindful of these things. You can be overwhelmed when you're starting the injection. There's so much to do, so much to think about, so much, but be mindful of the sterility. Post-procedure, the injection areas are not to be massaged. In filler, we do massage if you're molding, but in Botox, we do not do any massage. I apply an antibiotic ointment, ciprofloxacin usually, and tell the patient not to touch the face for at least 12 hours. If it's done in the day, I tell them, Kal subah take a bath in the next morning and let your face be. Some of them are finicky, they feel both sticky because of the ointment, they feel it's sticky. Then I tell them that you can use Bisleri water and a towel dip and gently dab it. Do not rub the injection sites. No hot fluids, no hot, you don't want steam or anything coming onto the injection sites, no makeup till the injection heals. There are very small pricks, but there are a lot of pricks. At least 10 to 12 pricks, even though there are 31 gauge, so you don't want any infection to happen. So you tell them to take the precautions. And no heavy exercise for 24 hours. Do not lay supine. We don't want the diffusion to vary. We've given in the sitting position. They say theoretically, if after Botox you go and lay down with higher doses, it can diffuse into the orbit and cause total conditions. So those, in general, precautions always remain. Problem happens with cosmetic patients.
How long would you continue the antibiotic ointment?
Just I apply it once. That's once. If I've done a full face volite or some other thing, then I would tell them to apply it once the next day as well. And if you have done more body surface area treatment, some people get hands, face, everything done, then I gave an oral antibiotic as well. So practice patterns vary. I've actually done a survey recently for this, if you remember it, you know. So they really vary. So, but yes, for Botox, in-office application is good enough, and you tell the patient not to touch the sites. People, what they'll do is they'll get the Botox in the day, and then in the evening they'll have to, for cosmetic patient, they have to go to a party, they'll put their makeup, and then they'll come back after 3 days with infection, boils, exactly where the injection was given. That happens. It is a known complication. So patient education, that's why the consent form is for your safety and for patient education. There are many things, like even right now between the two batches I may have missed some points here or there, but if it's all written down, at least you have the opportunity to discuss it. And learned patients discerning, they do go through each and every point and talk to you about it. It's all, you don't want to scare them. You have, in a filler, you have to lift the complication of blindness, but you tell them that yeah, we do it with a cannula, we don't do it with a needle, chances are less, we take precaution. So it's a patient education experience during the consent period. So now you're ready with the patient is lying down. This is at a reclining position. Your patient. You have your
makeup allowed after 24 hours.
Next morning they wash their face. Everything is allowed after that. You do tell them to report SOS if there's a swelling, edema, any problems there. Tell them. Especially the first time patients, even spasm patients, the first time that they're getting injection, they're very apprehensive. So it's good to do a call back at 3 days from the clinic, talk to them how you're doing. And if you're starting with a cosmetic patient and you feel you've underdosed, you're not sure. Nobody's ever sure of the amount of units needed for each and every muscle. It can vary from the right and left side of the face also. So you can always undercorrect and call them at 2 weeks. Not earlier, because the full effect will not come. With the same amount of dosage, with the same muscle bulk, the effect on the right and left may come at a different time. Depends if they're right-handed, they rub their right side more, they sleep on which side of it. So call them after 2 weeks, and then any residual wrinkle that is left, you can do a touch-up of 4 minutes or whatever is required. But not before.
What do you tell them about the duration?
So for Botox, the product says 3 months, but I tell them it varies from person to person. It could be 6 months also. It depends on what you're doing. But 3 months is what I generally say. If somebody is into heavy gymming, I say it may be a little lesser. And more important than that is telling them that the onset will take 3 days and the peak effect will come at 2 weeks. Because they'll get the Botox, they'll call you the next day, doctor, abhi to aa raha hai wrinkle. They'll send a video actually, ki abhi to kuch gaya hua nahi effects hai. So you have to tell them that onset will take 3 days. That is for this product, Botox. For Dysport, the onset is as early as 12 hours. They say one day it comes, action comes. It lasts for about 4 months is what they claim. For Xeomin, the duration is only 2 months. So Xeomin product, incobotulinum, doesn't have any protein, any preservative. So it's a very robust product. If you're going to the field to inject for spasm patients, that's the product you carry because you do not need any refrigeration. You don't need the cold chain. Between Botox and Dysport, Botox needs 2 to 8 degrees throughout, from procurement to preparation to injection to storage. Dysport is a little hardy, can go up to, they say up to 3 hours on room temperature also once reconstituted, but nobody would do that. You would get it injected immediately. So that is there. Once prepared, they say use within 24 hours, but studies have done which say that up to 6 weeks the efficacy remains. That doesn't mean that you keep using them for 6 weeks. You're starting out, you want to build your name in your practice, whether it's functional or aesthetic. So you take all the precautions to make sure your results are good, which includes these small steps of sterility, not injecting through the injection, through the marking pen, and making sure that there is no reaction, making the patient comfortable, not reusing one syringe more than 4 pricks so that the patient doesn't have so much pain. All these things go in a long way in establishing you as a trained injector, right?
The effect also passes off gradually, no?
It's not an overnight.
Yeah, it's not
an
overnight.
overnight finishing of the effect.
Yeah, yeah.
It, again,
It's not
the
a
muscle,
day.
how much you use that particular muscle.
The duration shortens also, 6 months.
The first injection for spasm will last 6 months, and then the same use. Yeah. After about 10 injections of Botox. So if the duration shortens, then you increase the dose first. If you're giving 50, move to 60, 60 to 70. Then after a point, you switch the product.
around the pre-tarsal I will not go beyond 12 maximum, but other areas, the glabella from 24 you can go up to 36. From crow's feet, if you're giving 3 points or 4, you can make it 5 points to beyond.
एक point में नहीं.
एक point में नहीं, because the circle of diffusion points बढ़ा है. And procedures you can do 2 points ऊपर नीचे. नहीं ज़्यादा. First Botox. Filler in the forehead can have a very lumpy and odd appearance also. You have fusion lines over here, then you have the glabella, you have a lot of vasculature. Filler in the glabella area can cause blindness quite easily. Volite is not a filler. Volite is a skin hydrating agent. Volite is a medical grade facial. Volite is a PRP without the time taken in a PRP of investing your blood. The volite of this is because volite is not cross-linked. It's pure hyaluronic acid which you are using in your cream. You're just injecting it in the dermis. It's that superficial. It's not even like going into the subdermis. It's not cross-linked. It is a good product. I wouldn't say it's just a feel good. It actually does lead to volume plumping. The second part is the number of pricks. Like how does PRP work? This is not just the product that you've injected, the number of pricks. Each prick is it's like acupuncture. It's microneedling. It's acupuncture. It's going to induce collagen. Any small prick is going to induce collagen. Mesobotox is basically for the pores that over here, the dark, chota. So वो hyperdilute. So you are targeting the erector pili muscle of the hair follicles and the sweat glands. Mesobotox is to reduce the sweating and improve the appearance of pores. But if you see over here, there's so many muscles. You can't give a high total units done in mesobotox in this whole area would be maybe 7 to 10. But hyperdiluted. Syringe यही जैसे आपने बना लिया आपका vial में ले लिया, then I take it in a 10 cc vial. I'll take 10 cc syringe. Sorry, I'll take 0.5 of this, and I usually take 4.5 ml for the saline. 0.5 मतलब 20 units थे इसके in 5 ml. तो 1 ml में 4 units. So जहाँ यहाँ पे इसमें मैंने 40 लिए थे, अब वो इसमें 4 है सर. और वो फिर एक इधर इंजेक्ट कर दिया, एक इधर. Multiple pricks. Well, superficial. Bleb.
Just move इसका ये हमको
just you keep visualizing the hub.
just
space. That's also, I do it with the nose also. यहाँ पे भी होते हैं pores. यहाँ pore दिख रहा है. For underarm sweating and palm sweating, then palm it's very painful. I haven't done many patients, it's very painful. But you can do the starch iodine test to mark the area first, because इधर sweat नहीं होता, इधर होता है. Axilla में भी that can be. मतलब there are ways of doing it. Migraine, forehead sweating, wrinkle लिखा है, expression नहीं है. I do not want to look Botox, but मेरी sweating में. Those are very challenging people to talk with because they definitely don't want to take something done. They want to walk out of the clinic without a bleb.
But what about the bleb with it?
It goes after 4 to 6 hours. जल्दी चला जाता है, थोड़ा erythema होता है. You can give them an antihistamine if you feel it. You can give them a painkiller if you feel it.
Actually, I had a problem with allergy with Prilox. पता नहीं Prilox की वजह से मेरे ended up with allergy to Prilox.
You could try just with ice maybe. Prilox.
तो Prilox नहीं लगा के मैंने एक बार दीपक के try की.
उससे कैसे?
उससे कुछ नहीं हुआ. उस बार कुछ नहीं हुआ.
So हो सकता है. लगाएं? चलो लोड करें. Any questions so far?
We are going to practice only in essential blepharospasm.
Okay.
Could you please repeat only
Yes.
that
So-
part? I don't want the functional part.
No, essential blepharospasm is functional. You want only functional. You don't want the cosmetic.
Cosmetic.
But when after your 5th essential blepharospasm patient,
Yeah, then I desire.
in the 6th, in the same patient, give Fractalis, give little bit here extra, make them feel, and then see the effect.
Then again I have to attend another class.
So benign essential blepharospasm, you have ruled out dry eye, you have ruled out your other causes of spasm. In BEB patients and neurologist consultation is warranted for Meeks syndrome and evolving Parkinson's disease. So you should always keep that in mind. Just straight away giving them, because once the Botox is done for 3 months, they're not coming back to you or going to any doctor because they're symptomatically relieved.
But with the medication also they come to us.
So you still have to give the injection, but at least make sure the diagnosis is established, because Meeks will eventually progress and involve the muscles of pharynx also. So at least you have to be on the safer side. It's an And in hemifacial spasms, you must always get an MRI with MR and vascular venography to look for any compression of the seventh nerve. So you ask them sequence of the seventh nerve course, and also get an EMT. Sometimes some cases have had stylomastoid foramen and tumors which have caused. So that is, it is not only safeguarding, it is required before you initiate the injection, because once the patient has received the injection, they will not seek any medical treatment till the Botox portion. Myasthenia, so ruling clinic history wise. Myasthenia patient will present if there is any history of any vague diplopia ever, or any history of one eye drooping or both eyes drooping and then recovering. I will probably get an evaluation with this around. Instead of doing the neostickle, we now do an oral perineostickle trial for 3 days. So instead of doing the injectable neostickle and then you need the attention after that, if we suspect myasthenia with an ice pack, with sign and all this also, we give them 3 days perineostickle. If this visibly, it's a TDS dose, I think 50 TDS dose, I think. Yes. And when they come back, we compare the MRD one, we compare the subjective response, and if we are suspecting myasthenia, then Botox is contraindicated. So for benign essential blepharospasm, we have to treat the pretarsal orbicular loculi, which is causing forceful closure of the eyelid. We have to avoid the levator palpebris inferior the spasm is usually not limited to just the eyes, it also affects the frown area, that's the glabellar area, and the crow's feet where the orbital orbicula is lying. Whenever you are treating one group of muscles like the broad muscles, you also have to balance it by treating the pro elevators. It needn't be a 1:1 dose, but a little bit of balancing is required, otherwise you will lead to some kind of malposition. Only treat the pro depressors, this will go up, this animation will become, the frontalis will become overactive and the patient may come back to you looking very surprised. So little bit of frontalis should be considered as a part of it. I usually prefer 5 points, but you can even do 4 points. So, for the sake of convenience, 4 points. One is at the medial limbus, upper lid, lower lid. One is at the lateral limbus, upper lid, lower lid. About 1 millimeter from the lash line. The injection is given with a 31 gauge insulin syringe needle with the bevel facing upwards, and the bleb has to form in front of you. Each point is given about 2 to 2.5 minutes with a circle of diffusion about 1 centimeter. That means when I've given it at the lash line and the diffusion is about 1 centimeter, it remains in the pretarsal orbicularis with a tarsal height of 1 centimeter and doesn't go into the preseptal part, avoids any LVS and ptosis. Then this is so over here if you see the lashes are coming here, the bevel is towards upwards towards me, horizontal, parallel, tangential. The hub of the needle, the tip of the needle will be visible to me. I'll inject, a bleb will form, and then I'll second point will be medial. Inject, and so you see the bleb. Every time you inject, just clean it up. Similarly on the lower lid, so I've given 2.5, 10 units. Then I look at the crow's feet. So they're very well formed over here. 1 centimeter away from the lateral canthus, outside the orbital rim. So the circle of diffusion is 1 centimeter. So if you stay outside the orbital rim, there is no way that the superior injection can go into the levator muscle. There are two ways of looking at it. One is use the right hand to inject the left side, but then the patient is seeing your needle in procedure. The other way is to inject in this direction, but the direction of injection has to be away from the orbital. If I'm injecting
over the bone.
injection will be superficial,
But over the bony surface.
yes, outside the orbital,
Yeah.
but away from there. I will not inject like this.
Like this. Okay.
What's the globe now?
Away from
These injections are also superficial where the blebs are supposed to form. One on the horizontal line and then corresponding superiorly wherever the line is. If you're coming too inferior, don't go deep because here the zygomatic, this major muscle is originating which is elevating the angle of the line. Basically the rim is also curved. So your center line you have marked, you are doing injection here. And above and below will not be in one straight line, it will be in a 30-degree line like this. Because the rim is also curved. The rim is not straight, it's curved. So accordingly.
So normally you inject your right eye with your left eye.
If I'm injecting here, no, I'll just this one left. If I'm same way.
Oh, you
I'll go to the other side of the patient.
And for the apraxia also you कितना ही dose देना है?
So I give 10 usually.
10 or 5.
2.5, 2.5, या फिर 2, 2, 2, 2, but one at the lateral canthus. किसके लिए?
Apraxia के लिए.
Apraxia में तो higher dose देना पड़ता है. थोड़ा सा मतलब we have to give more of orbital. I will go up to 30 units in the glabella.
और इसमें 2.5
Pre-tarsal में तो इतना ही. In fact, when we are increasing the Botox for essential blepharospasm with due to tolerance, when we are going up from 50 to 60 to 70, pre-tarsal उतना ही रहता है.
वहाँ पे लाइन बढ़ा देंगे.
हाँ, यहाँ लाइन बढ़ जाती है, इधर डोज बढ़ जाता है. बट pre-tarsal, then you add more points. Nasal ऐड कर लिया, levator nasal ऐड कर लिया. बट यहाँ ज़्यादा नहीं दे सकते because in your lag of thymus will happen. Your eye normal blink closure, epiphora हो जाएगा. Lot of eyelid malposition can also actually occur. And more the amount of dose, the greater the circle of diffusion. At the same point, when I'm giving हाँ
पॉइंट बनाने से अच्छा है.
नहीं अच्छा नहीं है. अगर तो आपने यहाँ पे 4 दे दिया तो 1 सेंटीमीटर नहीं अप्लाई किया, फिर ज़्यादा डेप्थ भी चलेगी बढ़ेगी, सर्कल ऑफ डिफ्यूजन. ठीक है. सो ये दोनों हो गए, क्रोज फीट हो गए हमारे. अब ग्लबेला. सो ओवर हियर द प्रोसीजर इन द डीप मसल. इफ यू आर यूजिंग द इंसुलिन syringe with the 31 gauge needle, you can afford to go perpendicular and fully inside. You can ask the patient to keep the frown and see where the bulk is. You can even hold the muscle and then. So you make them frown, hold the muscle and then you give the injection. Then for the corrugators, the deep head and the superficial head. So again above the orbital rim. Keep a finger here so that whatever injection is not diffusing downwards into the levator muscle. I prefer to go perpendicular for the deep head of corrugator. The muscle, you can see. So medial, so basically the frontonasal junction where the rim is. I prefer to go perpendicular. The other way of going is deep at 45-degree angle. Then for the superficial head, I'll go tangential. This injection is always painful because the branch of the supratrochlear and orbital is going to be there. So tell the patient that यहाँ हल्का सा pain. Nothing will happen if you hit the nerve. The Botox is not going to paralyze the nerve. There is no. It's only going to act on the muscle. But yes, this injection is always painful. 1, 2, 3, 4, 5. And if the patient has a bulkier procedure, we can just take 2 points. Then if there's a nasalis like lines over here, we can give circulation.
फिलर के लिए है कि सेंट्रल 2.5 you should not inject.
Yes. हाँ, फिलर में एस्पिरेशन भी है, सेंट्रल 2.5 जोन भी है. नहीं देना. बोटॉक्स दे सकते हो. बोटॉक्स आपका वैसे में भी चलेगा, इतनी लो डोज में कुछ नहीं होगा. बोटॉक्स इज फ्लूइड नहीं. बोटॉक्स इज फ्लूइड. दैट इज अ थिक विस्कस जेल. बोटॉक्स इधर जब नेक ट्रीट करते हैं तो मिड लाइन में नहीं देना क्योंकि वो वोकल कॉर्ड पैरालिसिस. मीक सिंड्रोम में कई बार हमें सेंटर इधर देते हैं. ऐसे ये देंगे पर सेंटर डायरेक्ट. अगर कर गया तो पेशेंट को बोल दो ब्रूज होगा, 48 आवर्स में चलेगा. ब्रूज से डरना नहीं. तभी एंटीकोएगुलेंट्स बंद करने का मतलब नहीं, हर 3 महीने पेशेंट नहीं बंद कर पाएगा फॉर एंटीकोएगुलेशन, स्पेशली इफ ही हैज अ कोमॉर्बिड कार्डियक इशू. So tell them that bruising is expected, and bruising can happen. We have done this muscle, we have done the crossfit, we have done the glabella, but I said balancing is sometimes required. So if the patient is, and usually patients are also not keen to spasm patients are to be repeatedly paying but I will like to add maybe 1 unit per point and a 5 point on the heel just to balance it out. But my forehead frontalis will be 2 finger breadths above the eyebrow to avoid any bruising happening, and I will ask the patient to animate in the wrinkle and mark the wrinkles. I will be injecting into the bulb, not into the depression, in the bulb.
Similarly for crossfit.
Similarly for crossfit.
On the elevation.
Not on the that's why the muscle bulb.
Okay, okay.
And not in this line, but here. Here also the injections are very superficial, level up, and you have to see them there. So deep सिर्फ आप इधर 3 में गए हो, यहाँ पे ब्लेब नहीं दिखा पर आप गए हो टेंजेंशियल. यहाँ पे ब्लेब दिख रहे हैं फ्रंटालिस में, क्लोज फील्ड में ब्लेब्स दिख रहे हैं, एंड प्रीटार्सल में ब्लेब. अगर आप यहाँ पे लेवेटर एलेक्नेजाइल लेबाई सुपीरियरिस पे ट्रीट कर रहे हो, LLA and QI, then you have to also make a 1 unit on each side. यहाँ पे ब्लेब बना है. कितनी लाइन्स है उस हिसाब से? 2 ही लाइन है तो 2.2, एक ही लाइन है तो आप 1.2 दे दोगे 4 यूनिट. 5 में होते हैं यूजली 1 लाइन नहीं होती, 2-3 तो होती है. We have a full fan, we have an inferior fan, we have a superior fan, and also the depth. If it's going beyond, then you give a 3.5, then beyond it also.
Multiple lines.
Because you can't increase the dose. यहाँ पे आप 4 के अलावा 6 नहीं दे सकते, फिर सर्कुलर डिफ्यूजन भी बढ़ता है. रिजोरियस हेमीफेशियल स्पैज़म में सर का पेशेंट स्पैज़म, तो रिजोरियस पेशेंट का ये भी हो रहा होगा. So 2 finger breaths away from the angle of mouth. With this preloaded needle onto the insulin syringe, you can go full depth. If you are using a 30 gauge needle separately, which is longer than this needle, you will go 2/3 depth. And in this area, we have to, if you are treating the depressor anguli oris, you will make the patient animate and you will mark this. If you go too medial, there is a depressor labia inferioris. Then the smile will become lopsided. This will go up like this. Straw drinking will become problematic. Speech will become a problem. So this along the marionette line is easy to mark. You're staying lateral, not going into the midline area. Mark the muscle, feel the muscle, pinch the muscle and inject.
Not going
सेंटर में नहीं जाना. मेंटालिस तो डीप देते हैं. अच्छा वो ऊपर नहीं जाएंगे, एकदम वो मिड लाइन होगा, मिड पॉइंट होगा. बेसिकली बिटवीन DAO एंड मेंटालिस DLI, बीच में नहीं देना, नहीं तो लिप ऊपर हो जाएगा. ये हम बाहर दे दो और मेंटालिस के लिए डीप. So HFS में what the textbook says is your center glabella has to be treated bilaterally. This muscle complex is one. And it says pretarsal over here, it says the crow's feet here, and it adds the risorius, and anguli oris that side is showing the effect. These are the points which you add. But in my clinical practice, I felt that for HFS patients also, I do bilateral crow's feet. Otherwise, they come with significant blink lag. They feel that this side treat किया हुआ blink slow हो गई, dryness आ रहा है, eyes irritated, eyes affected. I will not give the pretarsal here because there is no spasm, but I will give the crow's feet on the contralateral side. If the patient is having this, then you have to treat the zygomaticus also. If the patient, zygomaticus will be the zygomatic eminence, you can feel that. Uske 1 centimeter below it, deep. Basically that muscle is rigidity from the bone. 8 point देती हूँ मैं, 2 units. And then they sometimes have this यहाँ पे. Nasalis तो मैंने एक इधर भी point add करते हैं. Nasal flare के लिए जो हम dilator nares को देते हैं, कई बार I add that. Alec-Nasal का point is basically you ask them to animate the line that you see which is going down. Yes, where your NLF is starting. Yes. वो ऑलरेडी ओवर एक्टिव है ना, ओवर एक्टिव है। इनफैक्ट वो उठा हुआ है, नीचे नॉर्मल आ जाएगा। ब्लेब करना है इसमें नहीं, इसमें सुपरफिशियल ब्लेब बनाना ही बनाना है, क्योंकि यहाँ पे लेक्राइमल सैक के थ्रू थ्योरेटिकली बोला हुआ है स्टडी नहीं लेक्राइमल सैक से एलएलडी में आके थ्रोट में आ गया ये भी।
तो इसमें भी ब्लेब बनाना है तो न्यूजीलैंड इसके लिए है बहुत कम ही गैप है।
एनिमेट कर रहे हैं ना, जो बेसिकली जहाँ एनएलएफ शुरू हो रहा है वहीं आपका लेवेटर एलेक्नेजा आ रहा है। दिस मसल ना एनएलएफ के साथ ही है, तो उसको रिजिड में आप डिजाइनर्स थोड़ा सा मीडियल में हो जाता है और ऐसे ये बनी लाइन अगर है मीक्स में आपका बायलैटरल प्रैक्टिस में एक्स्ट्रा देना, आस्क द पेशेंट टू मूव द नेक फॉरवर्ड, सी द बैंड्स, ईच बैंड में 4 to 5 points, 2 units each, अवॉइड द सेंटर। जो बैंड 2 बैंड दिख रहे हैं वो है, एंड अवॉइड द सेंटर। कई बार इधर और इधर ऐड कर देते हैं, रिलैक्स हो जाए। ओरिजिन ऑफ प्लेटिस जस्ट along the अभी डन almost. I think we have started practice. But I'm far off ना, आ जाओ. So injection, everybody. चलो let's end off. So ideally you're going to need all this. Yes. Then ये उस डब्बे में डाल दो. एक मिनट level up, parallel, 1 millimeter dash line. Yeah, you can stretch the skin a bit. Any visible vessel, change the entry point slightly.
The tip should be visible, right?
The deep muscle bulk is the corrugated eyelid skin is sublevel fat. Over here, the bone is Risorius deep.
Subcutaneous था now it's a blade organ. Now let's blade organ.
And I'll be sharing my limited experience on these medications, or cosmeceuticals is the term for them rather than medication. So, should I go ahead? Should I start? So, if we look at the data from the Southeast Asia beauty and cosmetics segment revenue in the year 2020, it has been a whopping $25 billion US, out of which the highest comes from this personal care segment. So there's a big market for these over-the-counter, anti-aging, anti-wrinkle cosmeceutical products. And this data comes from the consumer. People are consuming these. So what exactly is the science of aesthetics? It starts from all the way from sun protection, which is the first and foremost proven science behind anti-aging. That's your sunscreen and sunglasses. Then there are products for direct collagen induction, which includes your retinols, vitamin C, niacinamide, which are called the active ingredients in a lot of cosmeceuticals. And then products like fillers and threads, like we discussed, which introduce the hyaluronic acid and induce collagen. Chemical peeling, dermabrasion. Then you have energy-based devices, which include your laser skin resurfacing, photodynamic rejuvenation, ultrasonic skin tightening. You have the neuromuscular relaxants, the botulinum, which is the injectable one, and some Botox in a jar type of topical peptides, which include arginine, Leuficil, Vialox, diaminobutyryl, and benzylamide diacetate. That's the DABA molecule, which we'll be extensively seeing in this presentation. These are touted as Botox in a jar because there's no injection, they're just applied onto the skin. And the last is the surgery, which is includes your deep plane facelifting, blepharoplasty for an anti-aging effect. So to see how they work, they actually work on different layers of the skin. We have the bone, we have the deep fat, then we have the facial mimetic muscles, then we have the superficial fat pad and the skin. Along with this, we have the smas and the fascia, and then the retaining ligaments, which are connecting the bone to the skin, that's the osteocutaneous ligaments. Contraction of this muscle through these ligaments produces the expression line on the skin and eventually the wrinkle. As we age, there's loss of hydration and the wrinkling becomes permanent, like a wrinkling of a raisin. The various products discussed target different layers. You have the peels, PRP, microneedling lasers on the skin, dermis, epidermis, and subcute. You have the neuromuscular relaxants, topical and injectable, targeting the facial muscles of expression. You have threads and fillers, which can be used to augment both superficial and deep. And then surgery, deep fillers and implants, which restore the reabsorbed bone. Another way of looking at it is like the face is like a building, the facade. So the innermost structure, the foundation, is by the bone. Overlying this, we have the deep and the superficial fat pads. Between the fat pads, we have the muscle. And then the outermost layer, which is the skin. So like we whitewash a building to make it appear fresher and newer and cleaner, the skin care targets the dermis and the epidermis to provide a smoothened effect. So sun protection, like I said, is the only proven method to delay aging. This targets the superficial layer of the dermis and epidermis by providing protection from the UV light. Other products of the skincare include a lot of active ingredients. If you look at dermatology textbooks, the list is long. The common ones amongst these include retinols, which can be prescription or over the counter. The retinol increase the collagen and elastin. They regulate the keratinocyte maturation and give an overall epidermis turnover time is affected. They normalize the distribution of melanosomes to reduce the pigmentation. And they make the appearance of those fine lines and wrinkles from the transmitted ligaments appear smoother by hydrating and rejuvenating the skin dermal texture. Then you have hydroquinone, which is a lightening or skin lightening agent which evens out the pigmentation by inhibiting the tyrosine to melanin production enzymatically within the dermis melanocytes. Then you have antioxidants which protect the DNA in the stem cells of the basal layer of the epidermis from reactive oxygen species and give a healthier overall even-toned appearance and a supple skin. You also have growth factors, which there's short-term data, but a lot of exosomes are coming in the market which are supposed to improve the skin quality and texture at different levels. And then you have keratolytic agents, which are your cleansers, your AHA and BHA hydroxyl acids, which loosen the epidermis and are used in conjunction with other skincare to allow the penetration of these and improve the efficacy of the skincare active ingredients. One such product by the Entod includes the iCirc Pro, which contains a vitamin complex, a very good hydration complex, a free radical scavenger, that's your glutathione, the ginseng extract, the niacinamide. Along with this, it also contains retinol. So the Aquazyl hydration provides overall hydration to the skin. The glutathione is one of the most powerful antioxidant and also skin lightening agent. The retinol is a vitamin A derivative that internally re-regulates the cell turnover cycle in the epidermis, smoothens out the epidermis, provides hydration and collagen, and leads to the effect of reducing fine lines and wrinkles. The niacinamide reduces the oxidative stress and helps especially in the under eye thin skin by locking the moisture. Ginseng fights the dark circles, dullness, and puffiness. Vitamin C and vitamin E are the antioxidants, and all of these come in a nanotechnology with a particle size of less than 15 nanometers with 20 times better absorption even with just a topical application with an intact skin barrier. The study done by the dermatology team investigating this product showed significant improvement in the dark circles and the periocular fine lines and wrinkles after 28 days of use. Pigmentation also improved due to the multifactorial combination of all the products within this, and patients were overall quite happy with it. Now they have also come up with the iCirc Advance, which contains tranexamic acid specifically targeting melasma and pigmentation, and also the iCirc Wipes, which are retinol free, but they contain tea tree oil and are very good for blepharitis patients. The second product that I'll be talking about targets a different layer. Now, we have done with the outer facade. Now we are discussing the muscle, that is the facial mimetic muscles, to reduce the prevention of permanent wrinkles by temporarily paralyzing the facial muscles, but without any injection. So like we know that the Botox acts on the presynaptic terminal by inhibiting the binding of the acetylcholine vesicle to the cell membrane and inhibiting its release. The other products which act presynaptically and are available in a jar, topical application, include Leuficil and Argireline, which presynaptically inhibit the release of acetylcholine in the neuromuscular junction. Compared to this product DABA and Vialox act postsynaptically. They bind on the epsilon subunit of the nicotinic receptor and prevent the ACH molecule from binding onto this. If acetylcholine doesn't bind, there is no depolarization and there is no muscle contraction, and thus the wrinkle is reduced. So botulinum toxin we have extensively discussed already, time tried and tested, but it needs to be injected. So coming to the Botox in a jar, one such molecule, the DABA, which acts postsynaptically by inhibiting the epsilon subunit. Having a small particle size of less than 500 Dalton, it has good topical absorption. It's absolutely non-invasive and reversible. But how efficacious is it? This is what we're going to see in the coming slides. Now, this product is available in over hundreds of different formulations across the globe, but we studied it with the Entod product, that's the Vasuki gel serum. So besides DABA, which is the neuromuscular relaxant, it also contains transforming growth factor beta, which induces collagen, antioxidants like ubiquinol, vitamin C and E, and the Aquazil, which is a patented hydration complex along with aloe vera. Many in vitro and in vivo studies with this product have shown good efficacy in reducing perioral and periocular fine lines and wrinkles. And the effect comes as early as 4 days, 4 to 10 days, and at 4 weeks the patient notices a visibly reduced wrinkle and smoother and even skin surface. A consumer trial done in the UK showed that more than 72% participants were quite happy with this. In my clinical experience in North Indian population, 14 people were recruited for the study and they were given twice daily use of this Vasuki gel on the full face, that's the forehead, periocular region, perioral, the neck, and the fine lines around the chin. 7 of them were Botox naive, had never undergone any cosmetic Botox procedures, whereas 4 had undergone cosmetic Botox with a wash-off period of 4 months from the last injection to avoid any bias. 3 patients of blepharospasm were also recruited because I wanted to see whether this does have some effect in reducing the spasm. Age ranged from 34 to 61 years, and main concerns before recruitment included wrinkles, preventive treatment, and pigmentation. Retinol was stopped 3 weeks prior to commencement, again to avoid any bias because retinol also reduces fine lines and wrinkles. Other products like peptides, vitamin C, moisturizer, and SPF were continued, but the data was not collated for who is using which product. The onset of action was noted as early as 10 days, and 12 out of 14 reported a smooth skin with good hydration. There was also improvement in pigmentation on the forehead. The ease of application and compliance was quite good. Side effects like mild burning sensation was noted in 8 in the initial 4 to 5 days of use, but resolved after continued use. Maximum effect was seen in reduction of the forehead lines as well as the crow's feet, followed by the under eye, perioral, glabella, and necklines. In the patients who were undergoing cosmetic Botox and were switched over to this after 4 months, they felt, of course, it was not as dramatic as Botox, but they were quite happy that by using this regularly, they could delay the next sitting off by more than a month. And the patients with spasm did not have any relief with this product. So overall, 11 out of 14 were quite happy, and these are some of the results. If we look here at the forehead from baseline to the 3-month regular use, there's improvement in the appearance of depth of these and the number of wrinkles. Similarly, in the crow's feet over here, there are about 4-5 lines which have come down to 2, and the depth has also come down. And there's improvement in the skin tone, texture, and pigmentation. In an elderly patient with dynamic as well as static rhytids, of course, the wrinkle is not going to disappear with this topical agent, but overall, the depth of wrinkle and the skin hydration did improve, and the patient was quite happy replacing their existing moisturizer with this product. Another patient who was undergoing regular Botox, even after the wash-off of the Botox, the wrinkles that are there, they have lightened with the regular use of Vasuki, and the pigmentation on the cheek has improved, but the wrinkle has not disappeared the way it does after injection Botox. Another patient, she was also undergoing cosmetic Botox and had both static and dynamic rhytids. She felt that the effect was there on the periocular and the perioral lines, and overall her skin texture and tone did improve with improvement in pigmentation. Patient feedback has been good so far, barring the spasm patients who were not comfortable with the product and it did not have any effect in them. They did ask, since the name Vasuki comes from snake and the product DABA is actually found in a snake venom, some people did ask whether it's vegan, so I reassured them it's synthetically manufactured, completely vegan, and no animals were harmed to procure it. So although it was not as dramatic as the injection, but there is no injection pain and there is some gain. with the improvement in skin tone, texture, and fine lines. And because of these findings, it has now become a go-to choice when in 3 particular situations which I want to highlight. So one, when a patient is coming who's using regular anti-wrinkle creams and has developed mebomytis because of the continued retinol use. We do see this quite common in perimenopausal women who are usually using over-the-counter or prescription retinols, and they present with epiphora and sudden intolerance. We want to stop the retinol, but they're not willing to let go of any anti-wrinkle regimen. So we introduce Vasuki, which is retinol-free and does have the same effect as in reducing fine lines and wrinkles. The second situation, when somebody comes for a cosmetic consult and says, "Doctor, no injections, but do start me on something which can reduce my wrinkles." So this is a very well-tolerated and economical product which can be used in these patients. And the third, when patients of regular cosmetic Botox want to increase the longevity, want to increase the time interval between subsequent injections, they can be offered Vasuki in the wash-off maintenance period. The last product that I want to talk about is a Bimatoprost solution, which has been marketed as Lash Factor. So this is again a nanotechnology-based prostaglandin growth serum containing Bimatoprost. Because of the small particle size, it has good topical penetration. It acts in the anagen phase of the cell of the hair follicle by increasing the hair growth, making it longer, increasing the size of the base of the hair, making it fuller, and also increasing the melanin production, making it darker. All of these are common side effects seen with Bimatoprost drops in glaucoma patients, but it has now been marketed as a hair growth and eyelash and eyebrow growth factor. The applicator is quite patented, and if you see the fine brush-like applicator, which can make sure that there is no spillage of the product, and where you're applying it is where it is limited. I personally have not used it for eyelashes. I am scared with the patient liking it too much and using it and getting prostaglandin-induced lipoatrophy. But I am very happy using it for alopecia patients. My dermatologist is very happy using it for patchy alopecia. And for people with loss of eyebrows, especially in thyroid patients and other chronic autoimmune disorders, they lose their eyebrows. So over there, this has shown very good effect. Not only has the hair density improved, but the existing hair have become darker, giving a fuller appearance. Another patient with severe alopecia, she was treated with Kenacort injections along with this. And if we see, again, the existing hair have definitely become darker, and the hair density has also improved, and this is with just 1 month of twice daily use of this product. So I'd like to summarize that these 3 cosmeceuticals can be made a part of anybody after today's workshop who's inspired in making aesthetics a part of their practice. It would be good to read about skincare, and these 3 products encompass most of the active ingredients available in the market, and they're quite well tried and tested and easily available in India and can be included in your regimen. Thank you so much.
Thank you, Dr. Aditi, for such a nice talk.
Well, you mean the wrinkles will come back again? So the medicines has to be continued lifelong, you mean to say?
Just like Botox is also reversible, it has its time period 3 to 4 months and then it will go away.
And same with lash factor, MB? So
Lash Factor Bimatoprost has shown irreversible lipodystrophy, irreversible pigmentation when we have been using it for topical as eye drops, the anti-glaucoma drops that we use. Yeah. So I mentioned that I am too scared to try it for eyelashes in my patients. I have treated patchy alopecia on the scalp and the eyebrow with it. And after stopping use, yes, the hair cycle continues. New hair will form. If it's not exposed to the lash factor, it will not have a prolonged anagen phase, and the condition will probably go back to what it was.
So you recommend to switch it on and off in between?
Yes.
For the lash factor, and for the other 2, you need to continue it to get an effect throughout?
Yes, just like any skincare regimen, to continue the effect, you need to
continue
on using
it throughout.
Yes. In lash factor, you can bring down the dose. Initially, when you want the fullness to appear, you're giving it twice a day. Then you bring it down to once a day. If the patient starts developing a rash or there's visible pigmentation which is not bothering the patient, then you stop it. So it is, again,
as per situation.
It is, again, we are not really dealing with a disease that we are going to modify completely. We are dealing with the additional treatment. For the second patient, I was giving Kenacort injections for the underlying inflammation, but just to have a faster effect to make her socially get back into her social circle. we added this and it showed good results.
Correct.
As long as they need it, they desire it, is what the...
Thank you.
So I request everybody, please wait for the dinner that we will be serving soon. And we have a small token given ceremony. We request Dr. Anita Chatterjee to hand over a small gift to Dr. Kasturi Bhattacharya. And we request Dr. Meghna Bhattacharya to hand over the token to Dr. Aditi Greval. Dr. Meghnad Bhomik. And the vote of thanks will be given by Dr. Sabita Katoch.
On behalf of OSWB, I extend my heartfelt gratitude to our faculty members, Dr. Kasturi Bhattacharya and Dr. Aditi Grewal, who took time off from their busy schedules to enlighten us today. Many thanks to Disha Hospital staff and Ranobir Bhattacharya for being the main organizers of today's event. The flawless audio-visual team led by Mr. Giri, awesome catering by Abhijit Shaha, venue decor by Anindo Shaha, all contributed to the success of today's workshop. Thank you all very much. We are very grateful to NTOD and its team who have been with us at every step of the way. And lastly, a very sincere thank you to all the audience members who had to alter their schedule to be with us here today. Hope this was all worth it. Thank you so much.
What she missed is she herself, Dr. Savita Katoch, has been enthusiastic with this oculofacial aesthetics, and she heads the subcommittee. This is the second workshop which is over, and we are planning the third one soon. Thank you very much, Savita, for organizing the entire show for us. Thank you.